Dr. Sulakshana, Senior Consultant Oncopathology at Sri Shankara Cancer Hospital. Over to you, ma'am.
Very good morning to one and all. At the outset, I would like to thank Dr. Srivatsa and the entire organizing team of UROVERSE 2026 for giving me an opportunity to talk on this platform in front of such big stalwarts in uro-oncology. So today I'll be talking about the advanced pathological predictors of prostate cancer beyond Gleason score. Okay. So whenever we talk about tumors of the tumors of any system, so the first thing we look at is the WHO classification of tumors. So as we all know, the tumors of the prostate are basically divided into epithelial tumors, mesenchymal tumors, hematolymphoid, and others. And the latest WHO classification of male urinary and genital tumors has a lot of emphasis on this high-grade prostatic intraductal carcinoma of the prostate and treatment-related neuroendocrine prostatic carcinoma, which I'll be talking about in the coming slides. Okay, so the diagnostic criteria for prostatic carcinoma is basically atypical glands, which are seen infiltrating deep into the stroma, and most important is loss of the basal cell layer, which we can see both histologically as well as by immunohistochemical methods. And the one thing that we look for in small biopsies is this. Can anyone tell me what is this? Which helps in diagnosis? Is the perineural invasion. And this is the gross image of a prostatic tumor, which is yellowish in color in the transition zone. Then whenever we talk of prostate, the most important is Gleason. So Gleason score was put forth by Dr. Donald Gleason way back in the 1960s and 70s, and several modifications of that have been put forward. So the latest of which is the 2015 ISOP modification. So as we all know, there are 5 patterns. Patterns 1 and 2, we usually don't, it's not recommended to report them either in small biopsies or in the radical prostatectomy specimens. So we report from pattern 3 to 5. So it goes from the most well-differentiated to the least differentiated, as we can see in this schematic diagram. So the most well-differentiated discrete glands then goes to pattern 4, whether it's fused glands, cribriform glands, and glomeruloid glands, and the least differentiated, where there are glands with the comedonecrosis sheets, nests, and cords of cells. So as in other tumors, the grade of the tumor is assigned by the worst grade or the least differentiated grade. But in prostate, we add the most primary histological pattern called as the primary pattern, and the second most pattern, which is the secondary pattern, and give the Gleason score. That is the importance of this. And finally, it is put forth into one of the 5 grade groups, which helps in risk stratification and diagnosis and treatment. Okay, so coming to the role of IHC prostatic tumors. Sorry, I had highlighted a few things, but it's not seen in the PPT. Anyway, I'll tell about them. So most important use of IHC is in metastatic cancer setting. Suppose there is a cancer of unknown origin and we suspect prostatic tumor. The 2 most important markers that are helpful for us is NKX3.1 and PSA, which help in saying that this may be of prostatic origin. Then other uses of immunohistochemistry is to determine neuroendocrine differentiation. So we use synaptophysin chromogranin. Then the proliferation index, that is the Ki67 or the MIB1. Then for therapy, we use the AR or the androgen receptor. And another most important use of IHC is for if there are some atypical glands or intraductal proliferation, which do not histologically fit into the classical criteria. We use something called as the PIN cocktail. Okay? So it is basically a cocktail of 3 markers. That is P63 and high molecular weight cytokeratin. We use CK5/6. These 2 stay in the basal cells. So in invasive prostatic tumors, we all know there will be loss of the basal cells. That is why they invade into the stroma. So we do P63 and high molecular weight cytokeratin to look at the basal cells. And AMACR is a cytoplasmic marker which helps in staining the malignant prostatic epithelial cells. So in the first picture, you can see that there is retained P63 expression in the basal cell layer, that is the nuclear staining. So even though the glands look atypical, it is not an invasive tumor. In the second picture, you see that there is retained staining of the CK5/6 in the periphery of the ducts. And there is also AMACR staining in the cells. So this is an intraductal carcinoma and not an invasive tumor. And the third picture, you see that there are pattern 3 glands which show loss of both P63 and CK5/6 staining and a scant staining for amaker. So these are pattern 3 atypical glands. So this is the pin cocktail which helps us in the diagnosis. So coming to the topic per se, what are the factors which help in predicting the prostate cancer aggressiveness, which is beyond the Gleason scoring? Gleason scoring itself is very difficult for pathologists, especially who work in the non-cancer institutes. But there are other factors which help us in guiding these, among which is the intraductal carcinoma of the prostate, also called as IDCP, which is an independent adverse prognostic factor regardless of the Gleason score. So it's strongly associated with high-grade disease, early metastasis, BRCA alterations, and poor survival. So in most of the cases, this intraductal carcinoma is associated with an invasive component. So in such a cases, we always incorporate it into the Gleason score as either a pattern 4, in which there are only cribriform glands, or as a pattern 5, where there are glands with associated comedonecrosis. So ISUP recommends that if IDCP is present along with an invasive component, incorporate it into the Gleason score. If it is present isolated, which is very rare, we do not put it in the Gleason score. So this review article I have taken from the Histopathology Journal 2026. The latest edition, there is a special edition on male urogenital tumors that has come out in January 2026. So a lot of very good articles have been there. So this also tells us about the recommendations of how the IDC is histologically diagnosed as well as graded. Then there are certain other terminologies that we may use. We pathologists ourselves get confused by saying atypical small SNR cells or atypical intraductal proliferation, when we do not know whether the tumor is actually an intraductal carcinoma because it doesn't have all the histological criteria, or whether the small atypical glands are actually infiltrating or not. So it is recommended that we don't use these ambiguous terminologies. And for especially these two types, we use the pin cocktail. And two other IHC markers that are important are the P10 and the ERG. So P10 again is a prognostic marker of tumor aggressiveness, and cytoplasmic P10 loss is frequent in intraductal as well as in invasive carcinoma. This, along with the ERG staining, which confirms prostatic adenocarcinoma, helps us in diagnosing such difficult cases. So coming to the second most important architectural predictor is the cribriform architecture. So note that not all pattern 4 is cribriform. Pattern 4 can be fused glands and glomerulite glands, but the cribriform one, especially the invasive, is very important. So because it is associated with increased risk of metastasis, biochemical recurrence, and disease-specific mortality. Coming to the other factors, tertiary pattern 5. Even less than 5% of tertiary pattern 5, if present, should be reported, which we do in all the cases, because it can alter biological behavior. The tumor volume and percent pattern 4 again is important because it correlates with genomic instability and biochemical recurrence. And quantitative grading is increasingly emphasized, which has also been incorporated into the CAP protocol of reporting. Then other factors include perineural invasion, which is associated with an extraprostatic extension and higher risk and recurrence risk. LVI, that is lymphovascular invasion, which predicts nodal metastasis and systemic spread, and EPE. As we can see here, there is extraprostatic extension into the surrounding fat, and here that which goes into the neurovascular bundle at the posterolateral aspect is also considered as EPE. And this is very important because it predicts recurrence after prostatectomy. The other factors is the tumor microenvironment factors. So these are coming up in almost all the tumors like breast, colon, and now also in prostate it's gaining importance, where we quantify the TILs or the tumor infiltrating lymphocytes, both in the small biopsies and the radical prostatectomy specimens. The PD-L1 testing by IHC is again recommended, which is important for giving immune therapy. And then there is a stromal reaction pattern, which has also come up in the recent papers. There is a terminology called a stromogenic carcinoma, which I'll talk about in my coming slides. Then other factors are the Ki proliferation index. As we all know, higher Ki is worse outcomes. The P53 expression, especially the mutant form, which we can also detect by IHC, is an independent predictor of disease progression and death. Then neuroendocrine differentiation. As I said, a new entity has come up in the WHO, that is treatment-related neuroendocrine carcinoma. Again, it is associated with aggressive behavior and hormone resistant. Other morphological factors include urinary bladder neck invasion and seminal vesicle invasion and margin positivity after radical prostatectomy. We know these two upstage the disease, and margin positivity especially is important. And the Gleason pattern at the area of margin positivity is also important, which we mentioned. Then coming to the molecular and genomic predictors, PTEN loss, ERK fusions and mutations in DNA repair genes like BRCA1, BRCA2 and ATM are strongly linked with more aggressive high-risk metastatic disease. So there are some genomic classifiers that are available like Decipher, Oncotype DX and Prolaris, just like we have Oncotype DX and MammaPrint in breast. So Dr. Aruna will be talking about this. She's the next speaker. She'll be talking in detail about this. Then the emerging tools and techniques are the liquid biopsy, where we analyze the AR receptor mutations or amplifications in the circulating tumor DNA, which allows real-time non-invasive assessment of especially CRPCs. Then AI, when we talk of AI, so that is coming up in almost all the fields, both medical and non-medical, so which helps in morphological assessment of the tumor, like tumor quantification and grading, that helps us. And based on certain deep learning models, you can say that this morphological subtype may show an PTEN mutation. So just a few lines about treatment-related neuroendocrine prostate tumors. These occur with either partial or complete neuroendocrine differentiation, and they represent 10 to 15% of CRPCs. And they occur by trans differentiation, and lineage plasticity plays an important role. The most important point to notice, they no longer respond to AR targeting therapy, and the mean survival time is 12 months. And they have specific epigenetic regulators and DNA methylation profile. So this is a picture of neuroendocrine carcinoma, where we can see that the tumor cells are very high grade. They have this classic salt and pepper chromatin. It is showing synaptophysin positivity cytoplasmic, and AR is negative. So I was talking about stromogenic carcinoma, so where there is a prominent stromal response. Yeah, just 1 minute, sorry. I think sir told me that I'm the opening batsman. He can give me 1 more minute time to just complete my talk. Thank you, sir. So where the glands are very, were squeezed in between the dense stroma. So this dense stromal reaction pattern is an important risk factor of disease progression and recurrence-free survival. Finally, about the molecular subtypes in CRPCs, I think again Dr. Aruna will be talking about them. I'll just skip this slide. And why are all these important? The prostate, the Gleason grading, the quantification, the grade grouping, and even in small biopsies, because again, they are all incorporated into the NCCN guidelines for risk stratification and staging of prostate tumors. So there are some studies which we have done in the Department of Pathology, and some of them have been published, and we have also presented them in various conferences, one of which is the tumor stroma ratio in prostatic adenocarcinoma. Then large format histopathology reporting, where we have taken the entire prostate. Instead of chopping them in 4 different quadrants, we have inked the entire thing and made a whole slice of that. We have made big slides and scanned them and viewed them. And other studies, the morphometric methods of tumor volume assessment in prostate cancer. So these are the studies that we have done at our department. And finally, thank you so much. Thanks to Srivatsa sir for giving me an opportunity to talk, and all my colleagues and my HOD and my students, and Philips Digital Pathology, which helps us in capturing such beautiful images. Thank you so much. Sorry, I overshot my time. Any questions? If we are delayed, I can take it later or during the coffee break.
Thank you very much, ma'am, for that excellent overview of evolving pathological landscape of prostate cancer. May I request the chairpersons to kindly give a token of appreciation to Dr. Sulakshana.
Just one word. Thank you, Sulakshana. I think you went through all the clinico-pathological features that will help in treating these cancers better.
Thank you, ma'am. Thank you.
While pathology gives us the structural understanding of the tumor, the next frontier lies in molecular and genetic signatures that define tumor behavior even precisely. Genomics is rapidly transforming cancer care by helping us identify which tumors are aggressive and which therapies will work best. So to discuss the role of molecular and genetic markers in prostate cancer, we invite Dr. Aruna Korlimarla, Principal Scientist, Molecular Research and Diagnostics, Sri Shankara Cancer Hospital. Over to you, ma'am.
Good morning, everybody. Thank you very much for the invitation to speak here. And as always, I'm very happy to be speaking about our work. Dr. Sulakshana, in the interest of time, I have kept the talk actually more like an update that we have about the molecular testing in prostate cancer. And Dr. Sulakshana has actually very elegantly done a great job of laying a foundation for all the tumor markers that play such an important role in diagnosis as well as the management of the disease. And I am going to sort of give an update about above and beyond that, what helps and complements in diagnostics as well as clinical decision making in prostate cancer in the molecular domain, with the tests that are available and how to go about testing them. Yeah. So the shift has been quite significant into molecular testing when we speak of precision oncology. So we'll discuss the most relevant molecular genetic markers that are actually transforming the diagnosis as well as clinical decision making in prostate cancer. This is no longer an option. It has been widely clinically adopted. So let's look at what are these tests that help us in diagnosis. So the molecular testing landscape in prostate cancer is organized into distinct categories, each serving a distinct clinical purpose. So both ASCO as well as NCCN now recommend germline testing for all patients with metastatic node positive or high risk localized disease. Why? Because it is an excellent predictor to response to PARP inhibitor therapy through synthetic lethality. So these drugs exploit the tumor's inability to repair the double-strand breaks that accumulate in a tumor cell, and therefore the concept of synthetic lethality can be adopted to use a PARP inhibitor that takes away the cell's ability to use other methods of DNA damage repair to rescue the cell. So these trials, actually the PROFOUND, TRITON, MAGNITUDE and TALPRO have all proven extended progression-free survival and an overall survival benefit with quite a high hazard ratio that will help with prognosticating. So the magnitude of the MAGNITUDE trial actually was very promising. There was about so the progression-free survival moved from 10 to 16.6 months, and that was very significant, so also the TALPRO. Next, we come to genomic classifiers, which are gene expression based. And the Decipher test is actually the most extensively validated genomic classifier in prostate cancer. And it holds actually a unique distinction as the only test that is available with level 1 evidence according to NCCN criteria. So let's look at what are the elements on the test. So it measures expression of 22 genes. It is a gene expression based assay. There are diverse biological pathways that are captured in these 22 genes that comprise of cell cycle progression, differentiation, stromal response, as well as androgen signaling. So it's performed on an FFPE tissue block, and it can be utilized, the biopsy specimen block can be utilized where there is a limited amount of tissue, as well as prostatectomy specimens. And they, so the test actually generates a risk score from the 22 genes expression. The score ranges from 0 to 1. So post-biopsy, it will help in stratifying the risk to conserving active surveillance versus immediate treatment. Post-prostatectomy, to guide adjuvant versus salvage radiation decisions, and in metastatic disease, to identify patients who may benefit from treatment intensification. Next, we come to Oncotype DX. This is very similar to the breast Oncotype DX, which we are all more familiar with. The Oncotype DX prostate is a 17-gene assay, also a gene expression PCR-based assay, QRT-PCR, and it generates a score from 17 genes, which are again of the same diverse pathways of stromal response, cellular organization, androgen signaling, as well as proliferation. The score generated ranges from 0 to 100. So the NCCN category here is 2A, and there are large trials like the PROTECT trial, which is a randomized trial and ongoing analysis as of 2026 and still recruiting patients. And we have very promising data that it is actually very superior in predicting the utility of extensive treatment. So it's best suited for newly diagnosed low risk and favorable intermediate risk patients, where the decision is between surveillance and immediate treatment. Then we have the Prolaris CCP, or the cell cycle progression score. So this actually, the rationale here is very clear. Highly proliferating tumors have a high aggressive potential, and that forms the core biological driver of the cancer aggressiveness. So the assay again is a gene expression assay. It quantifies the expression of 46 genes involved in cell cycle progression only, and this is now actually as of 2026 the most spoken of test. It is actually making a difference in the treatment changes and de-escalation of treatment in 72% of the cases. Can be used post biopsy to inform active surveillance eligibility, or post prostatectomy to determine the need for adjuvant radiation. So the test again predicts also 10-year disease-specific mortality with a hazard ratio of 1.7 per unit, and the clinical integration is it's still it's evolving. It's a little bit uncertain, but does show a lot of promise. So this is just a summary of the 3 gene expression tests. We have the Decipher, that is 22 gene, Oncotype DX 17 gene, and the Prolaris 46 gene expression assay. These are all in the different settings of metastatic setting, pathology at prostatectomy, and to predict 10-year disease-free survival. So the NCCN guidance are level 1 for Decipher, that's the one with the most clinical evidence, category 2A for Oncotype DX, and Prolaris, which both of the tests are still evolving. And there are many key trials which have a lot of data for these. Then we come to the liquid biopsy paradigm. Any solid tumor, actually what we see, it's like a tip of the iceberg. The information that we get at biopsy and the histopath report are actually much more than what meets the eye. As we move into the molecular domain, there are so many factors, molecular subclasses, different expressions that we still don't know, and it is very difficult to establish in a biopsy specimen. Liquid biopsy actually bridges the gap very beautifully, where serial biopsying is not feasible and where the tumor is not telling us enough information. The liquid biopsy bridges that gap. Circulating tumor DNA, they are tumor-derived DNA fragments which are shed into the bloodstream, and we have the technology to detect and characterize these fragments even at very low concentrations. So that's the reason it is getting vastly adopted in the clinic. Circulating tumor cells are intact tumor cells which are capable of seeding metastasis, and we can detect them, and we can perform protein and RNA markers on these cells. And the 2025 meta-analysis pooling from multiple studies has shown that ctDNA achieves 85% sensitivity, 88% specificity for prostate cancer specifically, and the performance is actually very commendable. And resistance mechanism detection is possible. Serial monitoring of the clonal evolution of the tumor is also possible, especially when we don't have repeated biopsy specimens. ARV7, this is another fast and upcoming marker. It represents the first validated predictive liquid biopsy biomarker in prostate cancer. That means it predicts response to specific therapies and also guides treatment selection. So the ARV7 is a splice variant of the androgen receptor that lacks the ligand binding domain. This makes it constitutively active in the cell. When this happens, it drives the tumor growth regardless of androgen levels. I'll just need another 2 minutes. And it's detected in either the tumor or in the circulating tumor cells. So the liquid biopsies are actually very successful in detecting this. So it can tell us information about resistance to enzalutamide-like therapies and also sensitivity to taxane-based therapy. So it is possible to change the track of treatment and revert to taxane treatment if we do detect the androgen treatment. Next, we come to urine-based tests, where this is actually more helpful in the clinic because there is a real-time treatment response monitoring that is possible. Exactly like the liquid biopsies, we can do these tests out of the urine cytology specimens, and this is more representative of the prostate cells. So urine-based tests are upcoming now, and then we are able to detect exosomes and other extravesicular molecules in the urine, and that help us to design a lot of diagnostic tests around them, and it is getting adopted into the clinic very vastly. And the integration is better here because urine is more prostate specific than serum, and it offers a much better signal to noise ratio. We have the PHI as well, which is actually, it combines the markers that are PSA, much more than just PSA. So we have the total PSA, the free PSA, and the pro PSA, which is a precursor form, and with a mathematical algorithm generates a score, and it is actually very clinically informative to bin the patients in these scores and be able to prognosticate. We did a small study of this in our institution, actually, of 50 patients, and not yet published, but very informative. Somatic alterations, like Dr. Sulakshana pointed out, the TMPRSS2 ERG fusion in the sample, and the PTEN loss and the CDH1 deletion. We also have the HRR mutations that we frequently run the tests, and we have the homologous recombination repair deficient genes that are detected in the NGS panel, and we are able to predict the HR defect in the tumor. So these are the takeaways. This is a summary table of at what setting we can use what test. So the germline HRR panel is has to be done for all metastatic prostate cancer. It makes the finding easier for also for prognosticating PARP inhibitor response. Metastatic castration-resistant prostate cancer, the liquid biopsy test with the ARV7 is very helpful. We have the genomic classifiers where in the as a biopsy as well as prostatectomy settings to use these tests, and we have the elevated PSA at the biopsy detection. So the genomic tests are not optionable anymore. They are standard of care. It will allow us to do fewer biopsies, smaller treatments, and better outcomes. The genomes don't lie. When in doubt, we have to go back to the tumor and ask these questions. One size fits all will not work. With the advent of molecular testing, the more information we are equipped with for treating, the better we can achieve better outcomes. Thank you very much. I thank my department, the Department
Thank you,
of
Aruna, for a very comprehensive coverage of the molecular testing. But one comment is that as we speak now, the urine liquid biopsy tests are becoming like more and more robust. Actually, right now, the NGS-based several marker testing is being done, and that is something which is happening, and very soon we will see NGS-based panel testing from the urine liquid biopsies. I think I know a group working in US on that. Thank you very much, Aruna.
Thank you. I can take questions later on. Currently, we don't have Indian labs who are doing the testing here. There are agencies like Medilinks, which institutions have MOUs with, and they collect the samples when they are prescribed for the test, and the test goes to US for testing. It is still very expensive. It is in the realm of couple of lakhs. Oncotype DX, I think, is 2.8 lakhs currently. So it has not yet reached, but I think the opportunity is there to develop the tests, and with the AI-based predictive tools, if we can get access to other databases, we can make our own tests more robust.
Are you aware of any centers in India who are using this currently for their treatment decisions?
Oncotype DX, I know AIMS Delhi and Max are both using. They have tie-ups and MOUs with Medilinks to send the samples to US.
Okay.
So
Thank
in the
you.
interest of time, we will postpone the questions. to
Thank
later.
you, ma'am. May I request the chairperson to hand over a memento to Dr. Aruna? Now we move on to our next session. For this, we invite our chairperson, Dr. Manohar T, Senior Consultant Urologist, Apollo Hospital, Dr. Prasad Mailarappa, Professor, Department of Urology, RMCH, Bangalore, and Dr. Ali Poonawala, Senior Consultant Urologist, Alpha Clinic, Bangalore, to take the dais and guide the academic session. From molecular biology, we now move on to the next important step in cancer
Just
care.
one this thing, we both of us chairpersons will thank the organizers for giving this opportunity to take this nice session. Thank you.
That is imaging, which allows us to visualize disease with increasing precision. With PSMA PET scan redefining staging and recurrence detection, clinicians now have unprecedented accuracy in disease mapping. So to discuss this exciting field, we invite our next speaker, Dr. Vijay Raghavan sir, Senior Consultant in Nuclear Medicine at Shankara Cancer Hospital. Over to you, sir.
Good morning, everybody. After the scintillating talks on pathology and molecular genetics, it's time to move on to what scintillating imaging can offer in prostate cancer. So the topic for today is PSMA and beyond, emerging PET tracers in prostate cancer management, a primer over the next 10 minutes. So surgery, radiotherapy, chemotherapy have all been the main pillars in the management of prostate cancer, and molecular imaging also is an important pillar which helps in staging, restaging, biochemical recurrence evaluation, and theranostics as well. So PSMA is something that has revolutionized the management of prostate cancer. So you can see that this PSMA, there are so many images over there. They are all evolved over the last 10 years. So PSMA got its FDA approval in 2021. Since then, we have seen so many of them. Releasing a new radiopharmaceutical is like releasing a new vehicle in the market. So many things that are required. Physiology needs to be assessed. Critical organ needs to be assessed. Whether it has an appropriate physiology that is good enough for imaging. Does it have a liver-based excretion, renal-based excretion, and so on. So each one of them have an implication on imaging as well as the theranostics and the stages of evaluation. If it has a renal excretion, it may impact on biochemical recurrence. So that's the way how it is. So PSMA is an important molecule, though it is prostate-specific membrane antigen. As all of us know, it's a misnomer. It's a folate hydroxylase, an enzyme that is expressed in so many other organs in the body. The important thing is that this PSMA is expressed in prostate cancer over 1,000 folds, and it gets internalized, and that's why it has an important implication in theranostics. So let's see one clinical illustration. This patient with a 72-year-old male with prostate cancer, and after several lines of treatment had a rising PSA, and this is what PSMA image could do. So such a crisp and clear, demonstration of metastatic lesions is possible with PSMA detecting. And that's the reason why NCCN and many other guidelines have incorporated this into the routine management of patients. PSMA has also evolved into guided surgeries like radio guided surgeries, picking up of lymph nodes, and so on. And the theranostics. Theranostic, this is routinely what we are using for metastatic cases. Vision trial, the therapy trials have all demonstrated important implications of PSMA therapy with lutetium labeling and its importance on progression-free survival and so on in hormone-resistant prostate cancers. Now we have an upfront PSMA trial released recently in which, even hormone-sensitive, the so-called the androgen modulation pathway naive cases have also been taken up, and they are showing good results. So for that to happen, it is important that the tumors express only PSMA and they are not dedifferentiated. So this is one example. See, you can see that there is only PSMA expression in metastatic lesions over there, whereas the FDG PET doesn't show any activity in the metastatic lesion. This is an ideal setting where you can use PSMA therapy for the patients. But if it is the other way around, if the tumors start expressing FDG as well, or if it goes into glucose metabolism, they do not respond well. So this is another case which we had a couple of months back. An 85-year-old man, metastatic prostate cancer with skeletal metastasis, and after several lines of treatment and several years of androgen deprivation. So what happened is his PSA started increasing significantly, and then even bone marrow suppression. This is what PSMA PET-CT and FDG could show. So you can see that there are a lot of metastatic lesions on PSMA PET-CT, and only few of them are intense, and many of them are showing up activity but not so much, whereas the FDG shows similar kind of presentation, and then there are a lot of those lesions have intense FDG activity. So what exactly is happening in this case? So is it something that these cells are going into some other pathway? Have they become resistant? So this leads us to discussion on PSMA and beyond. So androgen deprivation over a long period of time can lead to lineage plasticity, as we heard from the previous talks, where these cells, these adenocarcinomatous cells, can go into dedifferentiated, and they start expressing neuroendocrine manifestation, and then epithelial to mesenchymal transformation. Once we have mesenchymal transformation, which means that they can invade the blood vessels and go into lungs, and metastasis can happen. So why does this happen? So this is what is the point of interest. So as we heard from the previous talk, that ARV7 gene is responsible for modifying the androgen receptors, and then leading to downregulation of PSMA, and then leading to some other different lines of differentiation. So we do have alternate targets with which we can do imaging, as well as bring in theranostic capabilities. So there are so many things available, out of which we have something like urokinase related PAR plasminogen activators, and then histone deacetylase inhibitor related things, and then the bombesin imaging, FDG, FAP, and so on. But what is that which can be meaningfully transformed into imaging and theranostics will be the discussion over the next few minutes. So out of this, I have just chosen a few of them which have actually made some impact over the last 10 years. So we do have androgen receptor imaging, amino acid transporter imaging, gastrin-related peptide releasing imaging, FAP and somatostatin. We all know about it. So fluciclovin is an agent that was an exciting prospect in the previous decade. Fluciclovin is also known as FACBC. It's a cyclobutane derivative. It's a synthetic amino acid, which was FDA approved in 2016. It takes the pathway of amino acid transporter and gets into the prostate cancerous cells. So in this image, you can see that the smallest of the lesions in the bone, and then the lymph nodes very, very well delineated. And 3 trials also happened. The first one is the Falcon trial and the next one is the Locate trial to see the biochemical recurrence, which if fluciclovine can pick it up at very low PSMA levels, as low as 1.0 nanogram per ml in these two cases, which showed a pickup rate of around 64%. And then an Empire trial was also conducted in which, fluciclovine derived radiation planning was conducted, and it showed 3-year event-free survival of 75% with fluciclovine related planning compared to conventional imaging. So this is the way how it happened. But then once FDA approved PSMA, it started performing much better than fluciclovine, and it swept it off. So that's the thing. So, however, fluciclovine is still an agent of choice where PSMA downregulation has happened. So next is androgen receptor imaging, as we heard from the previous talk, where there is, ARV7 related mutation, and then once it becomes hormone resistant prostate cancer, there is downregulation of PSMA expression, while the androgen receptors start expressing higher on these metastatic cells. A comparison of FDG versus the androgen signaling, you can see such a huge difference in the same patient, where androgen receptors have shown significant metastatic pickup compared to FDG. Even PSMA wouldn't show any uptake in these cases. Lack of PSMA shouldn't be taken as response, while it has to be the other pathways which can be used in this. So it can help in predicting response to anti-androgen therapy and then CRPCs and so on. So role of FDG, we always do dual tracer imaging whenever we plan patients for lutetium PSMA therapy, because if the metastatic cells are in glycolytic pathway, they are not going to respond, and that is one of the important implications. FDG, however, does not have a primary role in routine staging or management of prostate cancer. So this brings us to the next exciting one of the things which is coming up, which is not yet FDA approved. This is gastrin-releasing peptide, an imaging agent that belongs to the bombesin group of molecules. There are many tracers, RM2, Neobom, and so on. They are all labeled with either gallium-68 or the copper-64, the PET tracers. And these tracers are expressed in prostatic cancers of low grade as well as in metastatic setting. And they also undergo internalization within the cells. That gives us the concept of theranostics in these agents. So a comparison has been made recently between PSMA and RM2, because PSMA has been a mainstay, and it performs so well when it comes to diagnostics. There has to be a comparison. So you can see that in this group, in ISUP2 tissue as well as ISUP5 tissue, and immunohistochemistry as well, you can see that when there is no PSMA expression on the histopathological images over here, there is no PSMA uptake as well. But gastrin-releasing peptide is showing such significant prominent uptake. On the other hand, when the grade is very high, there is PSMA uptake, while gastrin-releasing peptide is not showing any uptake on the imaging. So this is another image which shows head-on-head comparison between PSMA and gastrin-releasing peptide RM2. So just a few minutes. So you can see that this tracer has predominant renal excretion, as well as it is showing some pancreatic activity because of its physiological distribution in gastroenteric region. But the studies have shown that this expression in the prostate is only temporary. Over the few hours, maybe 2 to 3 hours or so, it gets washed out. So one need not be worried that pancreas will be a critical organ when we use that as a theranostic thing. So it gets washed out. So in this you can see that within the same prostatic histopathology, where there is one ISUP3, ISUP2. So in both these there is RM2 expression, while PSMA expression is seen only in higher grade. So what does this mean is that we are heading towards the combination of imaging. One imaging agent, because of such a heterogeneity of the tumor biology as such, single imaging agent may not be helpful going forward. So we may have to use we may have to come up with a molecule which will have dual capabilities. Already we have a radio hybrid PSMA which is FDA approved in US. So maybe we can come up with a molecule which will have bombesin receptor as well as capability to bind to PSMA. That will be the future. AI has already taken over, and we do have a software with which we can actually get the tumor volume in metastatic setting that has been incorporated into something called RECIP. Like the way how we have RESIST and PERSIST, we have RECIP, response evaluation criteria, and prostate. So all these are the future directions. So PSMA PET as of today continues to be the standard of prostate cancer imaging. When it comes to theranostic capabilities, the newer tracers do have important role, and those tracers which have been neglected in the past decade, whenever the PSMA downregulation happens, they are still important tracers which can be used. The only challenge is that how are we going to label it? The need for radiochemist or a need for a central radiopharmacy like cyclotrons within a town. So where the cyclotrons can produce F18 or copper 64 and then label these in their chemistry lab and then circulate it. That's the only way how we can improve the management. Thank you very much for your patient hearing.
Thank you very much, sir, for that comprehensive overview. May I request the chairpersons to kindly give Dr. Vijay Raghavan sir a memento.
Previously things. Practically, we all know that after post-radical prostatectomy, raise in the PSA biochemical recurrence, at what level you will ask us to do PSMA PET? Because we know that on biochemical recurrence, 0.2, 0.4, after radical prostatectomy, at what point you would advocate PSMA to pick up the lesion?
PSMA can pick it up above 1, sir, 1.0. It's
one regular PSMA?
Regular PSMA. 617.
Thank you, Dr. Vijay Raghavan. You have elucidated very nicely about what are the different radiopharmaceutical which are available beyond PSMA in terms of in the diagnostic as well as theranostic. Just I want to know in the clinical practice, there are so many radiopharmaceutical available. So when do you ask for PSMA? When do you ask for GRPR? When do you ask for other so there are different variants. So are there any particular situation when?
Sir, GRPR is not yet available, but that will be the future. Considering the way how it is behaving and the way how it is picking up even low-grade tumors, that will be the future. As of now, we are relying only on PSMA PET-CT because it is easily available. We can have an in-house laboratory where PSMA can be synthesized and used in the patient.
So when it comes to theranostic, is there any combination of now PSMA lutetium-177 which is used? Is there any combination of PSMA with other GRPR combination in terms of theranostics?
GRPR has been labeled with lutetium, and there is a trial going on which is called 3TPO trial. We are waiting for the results of that. The thing is that it is possible to have a cocktail of these things, lutetium labeled gastrin-releasing peptide as well as a PSMA, but provided that we have done an adequate evaluation of the patient and proper imaging prior to that. If there is no neuroendocrine differentiation and we have a case in which there is PSMA downregulation, PSMA upregulation in some lesions, which is very much possible in extensive metastasis. Some of the lesions may be avid with PSMA and some may not, and those lesions may be GRPR positive. We have to evaluate these things and then go ahead with combination therapy.
Thank you, Dr. Vijay.
Please give me a quick comment or moment.
Dr. Srivatsa N, Senior Consultant Uro-Oncology, Bengaluru, to give a talk on fusion biopsy, the new standard of care, mastering the art of practice. Dr. Srivatsa.
Thank you, sir, and a very good morning to you all. So the talk for today is MRI fusion biopsy, the new kid in the block. So what are the challenges that we routinely face when we want to evaluate a patient with prostate cancer is that, it starts from the time of diagnosis, because there are several limitations to doing a standard finger-guided biopsy or a 12-core truss-guided biopsy because of the extreme heterogeneity of the disease. A conventional biopsy method can either overdiagnose or underdiagnose patients, both of which can significantly alter the way we manage these patients. To counter this or to mitigate this major problem, MPMRI, that is multiparametric MRI, has evolved over a period of time and has now become the standard of care. The biggest advantages of MPMRI are that it can rule in clinically significant cancers, that is a Gleason 7 or more, and can rule out clinically significant cancers by missing those cancers which are typically indolent and not necessary to be treated. So the next challenge that has happened over a period of time is evolved understanding of the distribution of these prostate cancers. Historically, we are all used to the McNeil's zonal anatomy and McNeil's interpretation of early prostate cancers, which told us that more than 85% of prostate cancers arise in the peripheral zone, with few cancers scattered here and there in the transitional zone or the central zone. But all the recent papers, which these all are from post-2020, and what they have done is incorporate MPMRI pre-biopsy, and what they have shown consistently is that the proportion of early prostate cancers in the transition zone can be as high as 30%, and close to about 10% of these cancers can also be seen in the central zone, which are typically missed if we did a conventional finger-guided biopsy or a truss-guided biopsy. Not only that, these papers have also told us that most of us Asians have higher incidence of transition zone cancers, and whenever there is a transition zone lesion, it could be more aggressive, that is a Gleason 4 or Gleason 5 pattern, and some central zone lesions produce PSAs disproportionately higher compared to the other counterparts in the other zones. So what are the current challenges of the conventional truss biopsy? Most of the times we do biopsy with a cognition recall. We look at the MRI images in the console, then we make a mental map, we do a truss scan, and then assume that the lesion is here based on the MRI findings, go ahead and do a biopsy. This is significantly error prone. Nodules on MRI look different from the nodules on what we see in transrectal ultrasound, very typically like comparing apples with oranges. More than 40% of malignant nodules on the truss are actually isoechoic, meaning to say cannot be picked up at all. You cannot differentiate them and are very easily missed. Malignant nodules in the transition zone will actually have to compete with the benign nodules, because we all know the transition zone is full of nodules. So it is like picking, you have to really literally pick that one rotten apple from a basket of good apples. So it is again highly prone to errors. And then identifying central lesions on the truss scan may be very difficult. So this brings us to next step, that is doing a fusion biopsy. And what is MRI fusion? MRI fusion biopsy integrates pre-acquired MRI images with real-time ultrasound, enabling precision targeting of the lesions while doing the procedure. What are the principles? We have to first identify the lesion on the MPMRI. Then we upload these images onto a software, a fusion software for contouring. Then we do like a conventional truss-guided biopsy, we do a real-time transrectal ultrasound and fuse the images which are pre-processed from the MRI and merge it with the real-time ultrasound images, and then do a targeted biopsy. What are the types? We have, this is what we have all been using. Typically the first one, that is the cognitive fusion biopsy. It's a mental mapping. MRI ultrasound fusion is the current standard of care, and it is an assisted fusion technique. There are a few centers in the world which are also doing an in-bore MR biopsy, where the biopsy is done with the patient in the MRI console. What are the key indications? We all know about these things, so I will just rush through them. What is the essential pre-procedure preparation? The key is having a good MRI. So a multiparametric MRI acquired very well is the key, because this significantly alters the way we identify these lesions and the way they can be processed using the software and subsequently translated into real-time ultrasound fusion for a targeted biopsy. So what is the most important feature? That is the axial T2 image, and the most important thing is that the section, the slice thickness should be either 3 mm or lesser. A larger slice of the image acquisition may actually not help in the image processing, and therefore we may not be able to segment the images properly. What are the equipments? We just require a good truss machine with high resolution, and then we need that integrated fusion software. So it's not much different. It can be done both transperineally and transrectally. It's not much different from how we did a conventional truss biopsy. There is just an addition of one additional monitor, which is the which shows the fused images real time. So how do we do it? It can be done either transrectally or transperineally. Most of the world is now moving towards the transperineal route for several advantages. We need to do a real-time ultrasound and then segment it and fuse it with the MR images which are already processed, and then just go ahead and do the biopsy. The conventional practice is to do a targeted biopsy and then subsequently a systematic biopsy, like how it has always been done using the truss scan. What are the advantages? It improves the detection of clinically significant prostate cancer. It reduces the detection of clinically insignificant prostate cancers. It enhances the detection of hard to access anterior and transition zone tumors, and it requires a lesser number of biopsy cores overall, which significantly reduces the risk of post-procedural complications. And most importantly, two important things. Number one is it enhances the risk stratification because we are picking up the right lesion. So there is no over grading of the tumor, neither is there a undergrading of the tumor. Secondly, with the evolution of focal therapy, which Dr. Jiten will allude to in his talk, targeted biopsy is extremely important because it accurately classifies the disease burden. So it can typically rule in a patient into focal therapy or rule out a patient from focal therapy. These are the most important advantages of MR fusion biopsy. What are the impact on detection rates and patient outcomes? 30% relative increase in detection of significant cancers, 10% increase in patients who had actually higher grade of cancer who were missed on systematic biopsy, and more importantly, 13.3% reduction in pathological upgrading compared to the systematic biopsy alone. What are the limitations? Initial acquisition cost is high. Dependence on MR availability and access to specialized facilities are mandatory. We need a proper MR imaging so that the procedure can be successfully accomplished. And of course, the risk of false negative MRI lesions being missed is always there. What are the future directions? AI-assisted interpretation, MRI-only pathways, pure targeted biopsy. We are not there yet because we know prostate is a very heterogeneous disease, but with the precision trial reporting good outcomes, maybe we will start focusing only on targeted biopsy and skip the systematic scheme practice. And then integration with focal therapy, which like I mentioned, Dr. Jiten will allude to. What are the take-home messages? Improved detection, useful for prior negative biopsies and in patients on active surveillance. It aids in focal therapy and now is becoming the standard of care. Thank you very much.
Yeah, two things I want to add. In my experience, we found that you said that good MRI. In fact, good radiologist who is reading MRI is also important, equally important.
Absolutely, sir.
Number one. Number two, regarding the anterior tumors, you mentioned nearly 30%. Last year, I had a discussion with Japanese Urological Association where, in fact, Asians, what you mentioned is truly correct. And they defined 18% of these tumors are called as PEAT, prostate evasive anterior tumors. So they are more aggressive in kind of metastasis. So when 80% of these anterior tumors, they are missed and they are also called as PEAT tumors, prostate evasive anterior tumors, and they are more aggressive when you take out them on the biopsy.
Thank you, sir.
This one you had mentioned systematic biopsy with the targeted course. So targeted 2 cores per lesion or overall?
So currently what we are practicing is we take 2 to 3 cores from the target and another 1 to 2 cores from the perilesional area, sir. So both are important because of 2 reasons. One, there could be a fine segmentation error. So if there is a target, there is a higher propensity that even if we miss the lesion because of a segmentation error, in the perilesional area when we biopsy, the probability that we miss these cancers are less. So we are doing 2 plus 3 or 3 plus 3 per nodule, plus currently we are also doing a 12 core systematic biopsy. So effectively we are now close to about 20 cores in each case.
Yeah, what we practice is if there is a PIRADS 3 lesion, if it is suspicious, then we go for targeted lesion 3 to 4 and perilesional. Plus maybe here and there the sector biopsies. If it is strongly 4, then I think only target biopsy we are doing right now, which is very high yield. 5 to only targeted biopsy.
Only targeted biopsy, yes.
In fact, that prevents, because this prevents the acute retention of urine, more commonly, which is commonly seen in multiple transperitoneal biopsies or transrectal biopsies.
Can I ask a question?
Yes.
Srivatsa, is there a difference in outcome when an in-bore MRI biopsy versus a fusion biopsy that the urologist does?
Sir,
And the outcome, is there any difference? Yield?
No, sir. I mean, none that I can, I know of, sir. And in-bore biopsies are being done only in very select few centers, and they have started only recently, sir. So we'll have to just wait for some more time for the data to mature. Probably no center in India is doing an in-bore biopsy.
I heard that it is very cumbersome to do that.
Not really. About 10 years back, they did a workshop in Clumax. The first time it was done was in Bangalore. In Clumax. And it was done in the MRI gantry, and the number of biopsies which in-bore suggests is not as extensive as this. They only target the lesion. They don't do systematic biopsies. They only do MRI directed
Targeted biopsies.
Targeted
No,
biopsies.
the problem, Dr.
So,
Ramesh, the
two
problem
things.
is-
No, let me complete. 2 things. One is your cost of fusion software all reduces. It's only MRI directed. So the costing comes down. When the initial costing comes down, the number of cores that are taken are much lesser. So I just wanted to know if there's any difference in outcome because of this.
Right now, no data, sir. Not much data. And regarding the cost, sir, while I agree that the acquisition cost for a fusion biopsy system will be higher, the needle itself, the needle that they use during the in-bore biopsy itself runs into a lakh or sometimes more than that, because they need to use a non-magnetic. So the operational expenditure significantly rises compared to the fusion biopsy, sir.
It also require a deep anesthesia, wherein if the patient literally moves and then it goes out of the bore. That's also a major problem. One of the major problem they had was the requirement of anesthesia in that in-bore.
Classical in-bore MRI guided biopsies are done under general anesthesia. They have to position the needle, they have to bring out the patient, correct it, again correct after inserting the needle, check it whether it's near the lesion or not, then you fire it. And you need a special set of MR compatible biopsy guns and all those things. So it is not just the software. The hardware is also different.
In fact, they did with GA plus strong sedation. What happened when the anesthesia goes up with the strong sedation, the patient moves uncontrollably. So that also make a main problem, and then it falls into limited.
Thank you, sir. It's amazing that such a good discussion is happening, but we request the questions to be at the end because we are short of time. Not every prostate cancer requires immediate treatment. So active surveillance is an important strategy for oncological safety with quality of life. So however, selecting the right patients for this is very important. To discuss this, we request our next speaker, Dr. Rahul Tej, Consultant Uro-Oncologist, Visakhapatnam, to take. We invite you, sir.
Good morning, everyone. Thank you, Dr. Srivatsa, sir, and thank you, Shankara, for giving me this opportunity. Coming back, I am the first fellow, Uro-Oncology fellow here, and coming back and giving a presentation here, I feel very nostalgic and happy. So coming to my... No. So today I'm going to discuss about active surveillance in prostate cancer, who qualifies for it and how to do it right. So active surveillance is just a deferment of treatment, that we are not denying treatment for the patient, and most of these patients require treatment at some point, and around 40% of these patients require treatment at some point of the time. And in active surveillance, men are carefully selected through serial examinations, and at the first signs of high-risk disease, predominantly defined by the pathological and radiological changes, the cancer is treated within the window of cure. So we have to identify the pathological and radiological changes at a correct time when the disease is progressing. So this is the key here. So we all know that prostate cancer, when the PSA was introduced, there is a high steep incidence in the prostate cancer, but when that is coincided with the mortality from prostate cancer, there is a huge difference. The incidence of prostate cancer exceeds by up to 4 times, even in India, with the mortality rates. So not all men diagnosed with prostate cancer face equal risk from dying of the disease, and treatment is often, all the treatments, either radical prostatectomy or radical radiation, all are detrimental to the quality of life of the patients. Patient might suffer incontinence, erectile dysfunction, severe rectal symptoms. So all the treatments are often detrimental to the quality of life. That is why the patient selection is the key, and risk-based approach for active surveillance is the key ahead. And we all know in 2016, when the Gleason is reclassified, the Gleason 3 is almost, the Gleason pattern 3 is almost, Gleason 3 is almost equal to the normal patterns, and the Gleason 4 is where the severe changes in the pathology are taking place. And when the genetic makeup is also taken, there is a huge difference in the genetic. We can see the blue ones are the genetic markup in the Gleason 3, and when it goes to the up to the Gleason grade group 5, there is a change. And the genetic alterations in the pattern C are almost negligible, which shows that the Gleason pattern 3 rarely metastasize, and from the Gleason pattern 4 where the genetic alterations are taking place. So this is a retrospective observational study where they have observed about 141,000 patients with Gleason 6 prior prostate, and of which nearly close to 22,000 patients had radical prostatectomy and a limited PLND diffusion. And of the lymph node dissection, only 106 patients have came up with positive lymph nodes, only 0.48%. This shows that Gleason 3+3 rarely metastasizes to the nodes. And of the patients who have nodal metastasis with Gleason 3+3, the PSA levels are slightly higher, and also they have more clinical T2 disease. So from all this data, we know that the molecular genetics of the Gleason 3 pattern resembles the normal cells in most cases, of course not, and the metastatic potential of Gleason 3 is close to 0. But it is from the Gleason pattern 4 where the molecular hallmarks of the cancer start. So here the main shortcomings of active surveillance is to pathologically identify the high-risk Gleason 4 disease, and also in this the MRI and molecular biomarkers will help in identifying this disease. So this is the very important study which was published in 2023, the Protect-T study. It is a follow-up for 15 years. There are 1,600 patients, which includes mostly low-risk patients, and intermediate-risk patients are up to 24%, and high-risk patients are 10%. And death from all-cause mortality is 22%, and there is no difference between radiation, active surveillance, and radical prostatectomy. In all the 3 groups, there is no any difference. And death from prostate cancer is also similar in all the 3 groups, but metastasis in active surveillance is 9% versus 5% in treatment patients. And also long-term ADT is 13% in active surveillance and 7% in treatment patients. This is where there is slight difference, but death from prostate cancer or prostate cancer specific survival or metastatic free survival is same in all the 3 groups of radiation, radical prostatectomy, and active surveillance when you take Gleason 3+3. So coming to how to identify this Gleason 3+3 patients, or who actually qualifies this Gleason 3+3. So we have several risk factors coming to EAU, American and NCCN guidelines. So generally the low risk and very low risk and low risk in NCCN and favorable intermediate risk, these are the patients who fall under the active surveillance. So how to identify these patients? So the main determinants are PSA, when the PSA is less than 10 and PSA density is less than 0.5, and volume of the prostate cancer, the number of cores positive on the prostate cancer are less than 50%, and T-stage by distal rectal examination like T1A and T2A and pathological grade. These are the determinants which we identify to select the patients into the active surveillance. And like we have discussed in the previous talks, what are coming up are the genomics like Polarix, Oncocyte DX, Decipher, and MRI. These are all the future things which are coming up to include the patients, better select the patients in the active surveillance. So this is again an observational study which was conducted in about 1450 patients with a median follow-up of 77 months. And 7-year biopsy upgrade-free survival was close to 40% in Gleason 3+3. And 7-year treatment-free survival is close to 60%, which is very huge number, and only 40% patients progress and go on treatment at 7 years. So we can give a 7-year good quality of life without any treatment for the patients with Gleason 3+3. And almost all with treatment also, 7-year metastatic free survival is close to 99%. That is, the metastasis rate is very low even in active surveillance. And here the prostate specific antigen velocity and PIRADS 4-5 lesions on MRI were associated with higher risk of metastasis. These are the two components which they identified in this group. So this is another study which was conducted in MSK-CC, and the 2,664 patients with Gleason 6 were included in this study. And risk of progression between active surveillance and treatment is almost close to 0, which we can see. And risk of non-organ confined disease over time is also very similar in both the groups. So coming to the next point, is active surveillance, can we actively surveillance patients in young patients? And this is a study which was conducted, and almost 1,433 patients with age less than 60 were included in this study, and they found no significant association between age, time of treatment and recurrence outcomes after surgery. So even young patients who are 60 can be actively under active surveillance, and in fact it gives them better quality of life without any treatment. And another shortcoming is whether when there is a high volume disease, when more number of cores are positive with Gleason 3+3 with a low grade disease, can we actively surveillance, put them under active surveillance? And here 1,029 patients were included in the study, and it shows that volume of the tumor and low grade tumor doesn't any impact on the overall mortality or cancer specific survival. So high volume and low grade disease also, these patients also can be considered under active surveillance. Coming to the Gleason pattern 4, this is where we have seen that from the genetic markup changes when there is a Gleason pattern 4. So if you consider this, this was published in 2016, the 5-year metastatic free survival when there is Gleason 6 and PSA is 10 almost is close to 94%, and the same with PSA 2. But whenever there is starting of Gleason pattern 4, that is where the metastatic free survival comes decreasing. So any part of pattern 4 should be taken care. This is also same was observed in 9,600 men where the Gleason pattern 4 is associated with metastasis. This is also same thing. The amount of pattern 4 shows the metastasis rate. So how to identify this one? So this was conducted in MSK-CC again. So the core length, the amount of pattern 4 core length is taken into consideration while putting intermediate risk and favorable intermediate risk patients into the active surveillance. So whenever the core length is less than 1 mm, these patients can be considered under active surveillance. So the key components again here are age and comorbidities, comorbid conditions you have to take into consideration, and life expectancy, validation of diagnosis, patient education counseling, and inclusion of newer tools. So this is a chart from Priyas where how we have to do active surveillance. Just I'll skip through it. So when we have to intervene. So whenever there is a change in the PSA kinetics or PSA density, whenever the PSA density is greater than 0.15 or PSA kinetics is increasing, whenever there is a change in the DRE, or whenever the change in the precise score on the MRI, on the serial MRIs, whenever there is a change in the precise score, these are the main triggers for evaluation. So this was recently published in 2025 where PSA density as a dynamic prognostic factor for patient to consider patient to treatment was taken, and in 137 patients 0.15 of PSA density is taken into cutoff, and when this was taken into cutoff 131 progressed to grade 2, which is a very high number. So PSA density is one which tells us that the patient is progressing with the disease. And next, coming to the MRI, the precise criteria on MRI is one which helps us to take the patients into the treatment. The precise is taken into 5 steps. Just 5 steps. And initially, when the MRI is done and biopsy is done, both the MRI and biopsy are correlated. If the target lesion on MRI and biopsy are the same, then you can repeat the biopsy after 1 year. If the target lesion on the MRI and your biopsy are different, we have to reconsider MRI again and take a biopsy from the MRI specific lesions and then reevaluate again at 1 year. So if there is no progression on MRI, we will just continue with the follow-up MRI on further intervals. And if there is any progression on MRI, the lesion, mainly the volume of the lesion and diffusion weighted imaging characteristics of the lesion are taken into considerations. And if there is change in any of these conditions, then we subject the patient to another biopsy. So MRI is not foolproof, and in this study, when 207 men on active surveillance were followed by serial MRI progression did not correlate with upgrading, and almost 31% of the patients who are stable on MRI have upgraded in biopsy. So only MRI will not is sufficient, and always whenever you have to take into PSA kinetics, PSA density, and subject them to when there is a change in the PSA density, you have to subject them to biopsy even though your MRI is normal. This is another study which is showing in 15, it is a meta-analysis of 15 studies of 22,040 patients, which shows the MRI on follow-up has sensitivity of only 60% and specificity of only 75%, which is not, so you cannot take decisions only on your MRI. And coming to these genetic factors, we have discussed, Daka Madam has discussed in detail about the oncocyte DX, Decipher and all. So this is one study where genomic-wide association of 5,022 patients was taken, and they have followed from active surveillance to radical prostatectomy, and the genetic analysis of all these patients was done and 18 variants of new genes were identified. And you can see in this chart, all the curves are widely spaced, so that they tell us that the genetic marker changes when the patient is progressing from active surveillance to the treatment options. So in future, these might help us in identifying patients better. And this is also another study where 41 patients are where 2 patients from the lesion and one biopsy from the non-cancerous area were taken into consideration, and they were compared. And the gray areas show us the unique mutations, and orange shows the common mutations. So unique mutations are widely described in this, so which tell us that in future all this genetic makeup can be used in better identifying patients into the active surveillance. So biomarkers are already discussed, and these are the upcoming what you call risk calculators are also coming up. So coming to the active surveillance, so initially you subject the patient to the biopsy and you risk stratify the patient and you consider comorbidities and life expectancy and patient preferences. Rebiopsy if there is any difference in the MRI and your biopsy results, and periodic evaluation for the change, and you have to intervene when there is change in PSA kinetics or density, change in DRE or precise score on MRI, and upcoming are the MRI negative and genetic tests. That's all, sir.
Thank you very much, sir, for that practical perspective on surveillance. I request the chairpersons to kindly hand over a token of appreciation to sir. For patients who do require treatment, the field is moving towards targeted and organ-preserving therapies. Focal therapy aims to treat only the tumor-bearing area while preserving the surrounding tissue. So to explore this evolving treatment strategy, our next speaker, Dr. Jiten Jaipuria, consultant uro-oncologist, RCGI New Delhi, will enlighten us on this topic, which shows how technology continues to challenge traditional surgical paradigms.
while we are waiting for the presentation to load, is there anybody in the audience who believes in AS? Let me ask very honest question. And how many of you really do it? And what is the follow-up on these patients?
Yeah.
Yeah, Shri.
Yeah, so we are regularly doing active surveillance in our centers, sir. So as on date, we have more than 120 patients who are on long-term active surveillance, with the oldest patient being more than 6 years old on follow-up. Few of them, I would say about 13 of them have progressed, and we have had to treat them. None of them have become metastatic. And active
and you are talking about 3+3.
Yeah, we are just doing it for 3+3 and not 3+4.
You were saying something, Raghu?
Low volume.
Yeah.
If they fit criteria and if they are willing to undergo active surveillance,
turn both.
Okay.
Right. So I used to do 3,000 patients a year, but that was in UK. So on active surveillance. So so thank you, Srivastava sir, for giving me this opportunity. So my talk is on focal frontiers, non-surgical precision therapy in prostate cancer management. How do I move the slide? Right. So I don't have any conflicts of interest to disclose, but there is a clarification we need to understand. Focal therapy is not a non-surgical option. It is the least invasive surgical option. Please, I request my fraternity here to not do the grave mistake which the CTVS surgeons did when cardiac stents were first introduced, and they left it to the cardiology colleagues. Almost half of the jobs were gone later. They're still gone. This talk will aim to tickle your gray cells. I will not drown you with statistics and boring slides. So it will have 3 parts. First part will be what lessons we learned from history. Second will be about what has changed from the past. And then third will be how we need to adapt and what new we need to offer. So coming to lessons from history. So the strongest...
Can somebody give him a hand mic, please? He is becoming difficult.
Okay, sorry. So the strongest evidence we have in favor of radical prostatectomy, that it even does anything, when we compare it to watchful waiting, the oldest evidence is the SPCG4 trial. This is the only trial that shows, it really works. This ended when I entered medical school in year 2000, and the upper limit of PSA was less than 50, 88% palpable cancers. These are exactly the cases you would operate today. And at the end of 8 years, the improvement in survival objectively was only 6.6%. And when I became a consultant and I became a certified robotic surgeon in year 2018, they had 30-year data. This is the only data that truly exists. You need to live 10 years, and then you will gain 1 additional year of life with that radical prostatectomy operation. So at the end of 23 years, you end up gaining 2.9 years extra life. This is compared to TURP, channel TURP and orchidectomy. So screening for prostate cancer doesn't help as well. Lakhs of patients have been randomized. You just end up finding more cancers. The survival curves don't diverge before 12 years. And then patients die from other reasons. And we know why this happens. It's simply because of disease heterogeneity. It took us 3 decades to understand that not every prostate cancer is same. You need to look at Gleason pattern, how it is behaving within the prostate, extracapsular extension, to find those who will then ultimately benefit. So patients have been our teachers. And what we have learned over 3 decades of radical prostatectomy is we have saved few lives. And the number is this, residents can remember it for their exams. You need to screen 455 patients. You will save 1 life with the treatment that, that 1 patient will have. And rest will all be uselessly screened and treated and whatever. So nearly all will experience the morbidity of treatment, and the morbidity is significant. It's not a minor thing. So what happens in UK is all the prostatectomies in academic centers who participate in the true NTH study, they are externally audited, so you can't lie about your results. So if 100 patients come pad-free before a prostatectomy, at the end of 1 year, 33 patients are still using a pad. So everyone is pad-free before RALP. At the end of 1 year, 33 patients are using pads out of 100. 10 out of them are reporting significant problems with continence. Erections is a worse story. Before surgery, everyone has a strong erection. After surgery, only 6% without needing medicines. 12% erections will work with medicines. Rest, bad story. So what has changed about cancer? We are living longer. Over last 30 years, we have added 10 years of life expectancy. And patients are presenting earlier to us. So in the SPCG4 era, the median PSA at presentation was 13. And by the time Protect came, it dropped to 4.6. So patients are coming to us at an earlier stage, in a younger age. And then if we show them what my previous presenter showed, active surveillance data for 15 years to a 55-year-old, he will look at you and say, look, at the end of 15 years, I'll be what, 70? I should still be alive. But the data is actually this. If you actually plot it on a graph, at the end of 15 years, his risk of dying from untreated cancer is 1 in 10. His risk of dying from a heart attack is also 1 in 10. So cardiologists will give him everything, but you will say, wait. So patients have also changed. Everybody is now, they don't look at survival alone. My younger generation has changed. They look at quality of life, functional outcomes. They demand everything. They just have to be educated enough. We have started understanding prostate cancer better. We now understand that more than Gleason grade and extracapsular extension, it's a game of clones. So there is an index lesion which drives the primary biology. And if you can find it and treat it, most of the metastatic clones are coming from that single clone. So that's the game. We are able to see cancer better now. So with the improvement in MRI and PSMA PET, we are seeing lesions much better, much earlier, and including the index lesions. So MRI can see 80% of those index lesions. So now coming to the last part, what new do we need to offer? So this is Freddie Hamdy, the main lead author of the Protect trial, and this is his line. He'll write it on his epitaph when he dies. So for the average man diagnosed with favorable risk cancer, the worst thing that can happen in his lifetime is radical prostatectomy. And treatment has to be better than the disease. So the ideal to aim for is this. You find cancer in those who are likely to die from it at the earliest possible point where we can eradicate it with the lowest possible morbidity. This is what we really want. So let's deconstruct this. So find cancer in those. This is about a diagnostic test issue. You just make patients aware, find the right diagnostic test, and we are working on it. So we can find cancer. Find out who are likely to die from cancer. This is about case selection and patient and disease characteristics. If a patient walks with a wheelchair in, he's not going to die from that cancer. So patient and disease characters, we understand this also. At the earliest possible time, this is an imaging and disease visualization issue. We have sorted a lot of this also with MRI and PET scan. We can see lesions early now. Now this is the last thing, where we can eradicate it with the lowest possible morbidity. Now, if medical science or astrology or whatever gives you a patient age 55 with a 1 centimeter index lesion, Gleason grade 8, in the right lobe of the prostate, involving 1% of the prostatic tissue, rest of the benign biopsies from other areas, why would you want to subject him to radical prostatectomy? 99% of the prostate is benign, and this is the outcome you are going to give him. 33% incontinence risk, whatever, and 94% ED risk. So this is where the role of precision therapy comes in. And focal therapy is now trying to find its way across active treatment, whether it's active surveillance or unfavorable Gleason grade 2 or even high-risk cancers. Because what we have understood about high-risk cancers is local treatment contributes a low part to the overall survival. Systemic treatment matters more. In the modern era, focal therapy has passed multiple generations now. We can target any area of the prostate. We got HIFU, cryo, nano knife. Name an area, we can find the right energy for it. It's all about case selection. And please remember the word focal. I'm not talking about a big tumor within a prostate. Early lesion enough in one area, we can target this, make it Gleason 7 up to T3A. This can be managed. So morbidity and follow-up data is now there for 15 years. And 2 out of 3 men will not need any other treatment in their lifetime. When it comes to functional outcomes, this is what they will experience. Only 3% pad usage risk, and 11% will get a new ED. Compare this to RALP, where only 11% will end up with an erection after surgery. So in conclusion, focal therapy is a disease management strategy. It should not be called a curative one, because what you are going to do in focal therapy is treat the index lesion, leave the insignificant cancer out, just monitor it, they won't die. So the primary goal is prevention of metastasis and cancer-related mortality while offering the lowest morbidity risk. And retreatment is allowed, because if focal therapy fails, all other options are still on the table, including retreatment with focal therapy. We are reaching this ideal. This is the last slide. So now coming to India, so now UK is finding cancer in those issues very well. So what they have now done is, the first two talks were about genomic markers. They missed the polygenic risk score, which is the most important update, I would say, in the current era. Because we now understand that these are genes like BRCA1, BRCA2, P10, P63, they only contribute a minor risk to the overall risk of cancer development. Majority of the risk actually comes from SNPs. So these are small variations which club together. They increase your risk significantly when you bring them all together, and they have a PRS score. So in India, there is no data whatsoever. So in Rajiv Gandhi, we are trying to develop this PRS score. We have picked up data from the Pan-African 1 and 2 panels, which are African PRSs, and UK PRS barcode 1. And then we are trying to see if we match those, and then can we make it into our own Indian panel. Finding who are likely to die, this we have already sorted. Earliest possible time, we just need to work on awareness, and patients will come. And regarding the energy modalities, we have HIFU in India. Cryo is there in India. We have it in my hospital. IR is there. Your liver cancer IR guys are using it. You just need to learn how to use it yourself. RALP is already there. Thanks.
Thank you, sir, for this informative talk. Now we request the chairperson to hand over memento to. We request Dr. G.K. Venkatesh to hand over the memento to our chairpersons. We now move on to the next scientific segment of UROVERSE 2026, focusing on evolving strategies in the management of prostate cancer. Guiding the session will be Dr. Ramesh D, Professor in Department of Urology at RMCH Bangalore, and Dr. Giri GV, Head of Radiation Oncology at Sri Shankara Cancer Hospital, Bangalore. To begin the session with an important topic, highlighting one of the most precise forms of radiation therapy for prostate cancer, which that is prostate brachytherapy. To enlighten on this, we invite Dr. Karthik Rishi, Consultant Radiation Oncologist, to deliver this talk.
With the permission of the chairman, I would like to start my talk. Yeah. Good morning, everyone. I would like to thank Dr. Srivatsa for giving me an opportunity to talk about this topic of brachytherapy in prostate cancer. I would like to begin my talk with a lament. Brachytherapy in prostate is a dying art. It is really dying. And I am unable to even show a case to our postgraduates to see how brachytherapy is done in prostate cancer. There are many reasons for this. One is that the practice has reduced significantly because more and more prostatectomies are being done. Earlier, for high-risk prostate cancer, prostatectomy was not being considered, but now routinely it is being done for all risks of prostate cancers. There's external radiotherapy has improved tremendously. You now have all kinds of techniques like IGRT, SBRT, protons are being used, and now MR Linacs have come up, which all are very attractive, and they're all being used to treat prostate cancer. So when I have an option of an invasive procedure like brachytherapy versus an external beam treatment, it is very difficult for us to convince patient to go for an invasive procedure like brachytherapy. But I'm here to tell you that brachytherapy still has a role and it is very useful. In fact, there was an article on it, brachytherapy in prostate cancer, where has it gone? So despite comparable outcomes, low morbidity and cost effectiveness, people are still not using brachytherapy. But why are we talking about brachytherapy in prostate cancer? Because prostate is an accessible organ, and literature and studies have shown that higher the dose you give in prostate cancer, better are the results. So with brachytherapy, dose escalation is extremely possible and very easily delivered. It reduces the overall treatment time. In just 2 days, your treatment is completed as compared to say 5 weeks or 6 weeks of external radiation. There are critical organs nearby like rectum and bladder, which can be protected easily, and it's easily visualized on imaging. So what are the indications for brachytherapy? It can be used for all risk stratification. As per NCCN, we now have 6 risk categories, and brachytherapy can be used as a monotherapy for both very low and low risk and also favorable intermediate. It can be combined with external beam radiation as a boost for unfavorable intermediate, high risk and very high risk prostate cancer. So there are 2 types of brachytherapy now. One is the low dose rate or the permanent brachytherapy, where radioactive seeds are placed inside the organ and they are kept there permanently. This is not routinely done in India. And the other is HDR brachytherapy or temporary implant, where we put needles inside the prostate and treat only the prostate. So this is a temporary implant, and once the treatment is over, the needles are removed. So what are the advantages of HDR brachytherapy over a low dose rate brachytherapy? It is very practical. You don't need a special device like you need for LDR brachytherapy. Most centers will have a HDR unit for treating gynec malignancies. You can use the same machine for treating prostate cancer as well. You can allow for a greater implant volume, including the seminal vesicles, and optimization can be done. In low dose rate brachytherapy, if your implant is wrong, you can't change it. Whereas in HDR, it is possible to optimize the dose according to it. Low alpha by beta tumor. So prostate cancers are generally slow growing. So a higher dose per fraction generally tends to benefit in a slow growing tumor, and that can be delivered with brachytherapy. Radio protection, minimum isolation and reduced cost. So over LDR brachytherapy, the JECESTRO-ACORP guidelines recommend that you do HDR brachytherapy in special situations like wherever the prostate gland is very large, like more than 60 ml, provided there's no pubic arc interference. For a T3 prostate cancer, it can be combined with external beam radiotherapy to deliver. Even if TERP or HOLEP has been done, you can still do brachytherapy, and it is preferred over LDR when there is extensive calcification in the prostate gland. There are some contraindications for doing it. The absolute contraindications are if it's a metastatic disease, if the patient is medically unfit for anesthesia because spinal would be required, if there is a pre-existing rectal fistula, it should not be considered. If there is no proof of malignancy, say it was only you're treating based on elevated PSA alone, you should not be offering. and ataxia telangiectasia, where radiation is contraindicated. Some of the others are relative, and based on a case basis, we can select for brachytherapy. How do you sequence brachytherapy if you are doing it as a boost? Most of the times what we do is we start with brachytherapy, because if you do after external, there is edema of the gland and it can be misleading. So you start with brachytherapy, wait for about 4 weeks, and then you give external beam RT. If you are doing low dose rate brachytherapy, it should always be done after completing external beam radiation. There are some prerequisites which are required for prostate brachytherapy. You need to have a transrectal ultrasound and HDR under the same roof. Dedicated systems are available but expensive, and it is preferable to have what is called as a side firing probe in ultrasound. So this is how a side firing probe looks like. This is a front firing probe and this is a side firing. So advantage of this is, if it's a front firing probe, you'll end up pushing the prostate gland, and that can lead to a change in the anatomy and you might implant in the wrong area. But with the side firing probe, it is easier to do it. So diagrammatically, this is how a prostate brachytherapy is done. You have a transrectal ultrasound and it will show you where the lesion is, and then you put the needles according to the ultrasound guidance. You have dedicated systems mostly for LDR brachytherapy. You have a grid for guiding the needles, and you can see the grid here on the prostate, and these grid will have markings, so you will know where exactly to place. For example, A2, B3, C4, like that. You have values which through which you can put the needles here, and you can contour on the ultrasound and treat at the same time. But these are dedicated systems. They are used in high volume centers and it's not available everywhere. What we do here is a temporary implant using what is called as the Syed Neblet prostate template. So this is a HDR brachytherapy temporary implant. So what we do is we use transrectal ultrasound guidance, and through that we put the needles into the prostate gland. And this is how the dose distribution will look like. Very conformal. It will be confined only to the prostate, avoiding the bladder and the rectum. And this is our connecting tubes through which the source goes in, treats the prostate and comes back, and we can remove it once the treatment is over. We can also use MRI for planning. We have what is called titanium needles, which are MR compatible. So it is easier to see the organs on the MR. You can make out how only the seminal vesicles are getting treated here. The bladder and the rectum are completely spared. So where possible, MR planning also helps in giving good dose distribution. There are many dose recommendations which have been published for brachytherapy. Commonly used are 45 and 25, or even lower doses can be given. If it is used as a boost, you give about 11 to 22 gray in 2 fractions. One of the important use is recurrent prostate. If you have given external beam and you want to re-irradiate, brachytherapy is a very good option to re-irradiate the prostate gland to a dose of 36 to 6 gray. It will be very focused and it will protect the organs at risk. So even the ABS recommends that clinical outcomes of HDR are excellent and can be used routinely for treatment. What do we do in our place? Our policy is to use HDR as a boost. We use 11.5 gray into 2 fractions or 9.5 into 4 for monotherapy. We are very careful about what dose goes to the critical organs, particularly the urethra. We make sure that it receives less than 125% of the prescribed dose. Rectal dose is maintained, and you can also play around with the dose. Since prostate cancer is seen more in the peripheral zones, you can contour or you can optimize your dose to reach the peripheral organ more than the central part. So that way you can give more dose there. So there are definite advantages of brachytherapy over IMRT. It's a faster treatment, gets over in 1 or 2 sittings, less investment, it's cheap and radiobiologically superior. Results have also shown that you have very good 5-year survival rates and even 10-year survival rates with brachytherapy with very minimal toxicity, urethral stricture about 4.2%, but it gives good survival. So in terms of comparing external beam alone with brachytherapy, you can see when you are just comparing external with brachytherapy, the graphs separate significantly in favor of brachytherapy. But when you are adding ADT along with this, the graphs significantly separate over a period of time. So there is a definite advantage of adding brachytherapy even in today's external beam era. There are some toxicity, acute toxicities are dysuria, some hematuria, obstruction can occur which will require catheterization, but they are all temporary and reversible, and usually within 1 or 2 weeks patient becomes normal. Some delayed complications can occur, but they are very small, and a carefully planned case you can avoid most of these. Last slides. You have 1% incontinence, rarely rectal ulceration if there is a pre-existing rectal damage, and very less number of erectile dysfunction can occur if in an older patient. So to conclude, the evidence strongly suggests that it can be used as a definite treatment or as a boost to external beam radiotherapy. It has excellent local control, very good post-treatment health-related quality of life, and it should be considered as a mainstream option. But unfortunately, brachytherapy is in the ICU today, and it needs an urgent revival. Thank you very much.
One question or a comment. Urologists generally don't like to send patients with large prostates or with significant bloods for radiation therapy. But your slide suggested that brachytherapy is good for patients with more than 60-gram prostate.
Yes, sir.
Right? So how would you...
Sir, one of the things we need to remember is very rarely we give radiation alone. It is combined with ADT and then it is done. So ADT most of the time shrinks the prostate, sir. So that makes it easier to do the procedure.
Thank you very much for that interesting talk, sir. May I request the chairpersons to kindly hand over a token of appreciation to Dr. Karthik, sir. We've had a lot of stimulating sessions, and unlike prostate cancer management, the management of caffeine deficiency is quite straightforward. So we have coffee available to anyone who needs a quick recharge shortly, in about 10 minutes. We now move on to what promises to be a lively and intellectual stimulating debate. The topic is intermediate risk showdown, active surveillance or focal fire. Intermediate risk prostate cancer often sits in a clinical gray zone where treatment decisions require balancing oncological control with quality of life. So arguing for active surveillance, we have Dr. Sanjoy Sureka, who is Professor of Urology at SGPGI Lucknow. Due to personal emergency commitments, sir will be joining us live via Zoom. And presenting the perspective supporting focal therapy is Dr. Sanjay Adla. He is a renowned uro-oncologist from Apollo Hospital, Hyderabad. Sir is here with us. So let this debate remind us that medicine is not always black and white, but sometimes it's about choosing the best shade of grey. Over to the speakers.
Am I audible? Am I audible?
Yes, sir.
Yeah. So should I start?
Yes, sir.
Yeah. Thank you, Dr. Shibats and Shankara Institute for giving me this opportunity. First of all, I want to share my humble apology for not being present physically there because of some medical emergency. So today's debate is about active surveillance versus focal therapy in intermediate risk prostate cancer. The motion before us today is not about doing nothing. It is about intentional evidence-based strategy of active surveillance in specifically favorable intermediate risk prostate cancer. When I used to be an audience and used to see Dr. Sanjay Adla being a debater, I always been scared of him because he is fantastic when he is doing a debate. So today already I'm little scared because the way he is staring at me. However, I'll talk about the evidence. I don't want to debate with him. So. As we know that prostate cancer is biologically very heterogeneous malignancy, with many of the tumor demonstrating very indolent natural histories of spanning decades. In localized prostate cancer, the real challenge is not treating the cancer. The challenge is avoiding unnecessary treatment. Why this debate exists? If we see the for decades, the level of intermediate risk prostate cancer has triggered a almost reflexive move towards radical treatment, most commonly radical prostatectomy. Yet, we now recognize that this approach often leads to overdiagnosis and overtreatment, exposing men to life-altering complications for cancers that may never have threatened their survival. Specifically in favorable risk group when the PSA is less than 10 to 15 and less than 50% positive cores in grade group 1 or grade group 2, 3 plus 4 digits. So the clinical dilemma here is to treat whether the patient should be treated immediately with some form of surgical management like radical treatment or the fancy focal therapy, or they can be monitored safely. The key question is, are we treating the cancer biology or we are treating the anxiety of the patient when we are considering focal therapy? Or we have a new fancy tool that should be used. Over the last 1 decade, there are lots of evolution happens in the paradigm of active surveillance. When I was resident in way back early 2010, the traditional approach being taught to us that every patient requires a fixed interval biopsy at 1 year, then 3 years. However, there are lots of shift in understanding of this biology of prostate cancer, and we have lots of newer tools like MPMRI, biomarkers integration, and this risk adaptive approach has also make the active surveillance is a very attractive option. So active surveillance is now not being followed up with a rule-based strict protocol anymore. It now integrate PSA monitoring, MPMRI, confirmatory biopsy, genomic risk profiling, and selective repeat biopsy whenever indicated. The goal is to delay or avoid overtreatment and treat only if progression occurs. So there are lots of evidence that support that active surveillance is a good to go modality in case of intermediate selective group of intermediate risk prostate cancer. So the largest evidence came from the Protect trial in more than 1,600 men has been included. However, and they found that 15 years prostate-specific cancer mortality is almost same in patient with surgery and active monitoring. However, majority of these patients are low risk. And there are other trials that looked into the role of active surveillance in intermediate risk group. And there are 15 to 30% patient had 10 years of progression. However, we can spare these patients safely in almost 85 to 70 to 85% of the patient without any treatment. So the safety and efficacy of active surveillance is well established. There is another concern that there are high dropout rate in patient with active surveillance in intermediate risk group. But the Staticans trial, which recently published, showed that 85% remain on active surveillance if they are counseled properly. So now I'll come to the appeal of the focal therapy. As we understand, it's a very fancy therapy. It treats the index lesion, preserve the continence, preserve the erectile function, though it is debatable. There are many techniques are available, but most commonly used techniques are HIFU, cryotherapy, and some other form of therapy. But key question is, does focal therapy solve the biological problem or it is an hype? The best evidence is a recently review article which is published in 2025. If you read the article, and ultimately they concluded that although significant advancement has been made, the challenges such as lack of long-term data, treatment protocol standardization, and regulatory hurdles still limits the widespread adoption. The Falcon, the focal therapy consensus and nonsensus, this is the best evidence, but you have to understand this is a Delphi consensus, not a very good strong level of evidence. They suggest that in selective intermediate risk group, though there are lots of disagreement during the Delphi consensus, that this is a focal therapy is a good option. However, if you see other guidelines, there are doubtful and it is still investigational. there are other evidences, whatever, if you see the literature, none of the focal therapy considered as a standard option for treatment, but it is an alternative to active surveillance in low-risk prostate cancer. So the problem with focal therapy is we need to understand the prostate is a multifocal disease, and study shows that 60 to 80% prostate cancer contain multifocal tumor foci. There are certain limitations because of MRI, because whenever we consider the focal therapy, MRI is the key investigation and modality that guide us for the focal therapy. Significant cancer, approximately up to 20%, can be missed in MRI. So treating only index lesion may leave significant disease untreated. Focal therapy treat what we see, not necessarily what exists. And there are also lack of robust oncological evidence. Whatever evidence we have is short-term and very heterogeneous. The oncologic durability of the focal therapies remain uncertain. The other problem of the focal therapy is after focal therapy, patient still requires surveillance. If focal therapy convert the patient into surveillance patient, why enthusiastic surgeon showcasing fancy options to treat the anxiety if surveillance is inevitable, and why to intervene in the first case? So as I already shown the good evidence in favor of active surveillance, it avoid over-treatment, preserve quality of life, evidence-based outcome. We know the long-term outcome is good in a selective group, in a selected patient of favorable group of intermediate risk patient. Treatment is still absolutely possible if disease progress. Now we have risk-adapted approach that has made it more attractive. We don't need to do biopsy, protocol biopsy in every patient at 1 year, or subsequently we can follow them up with MRI and other modality, and we can choose the patient who require biopsy. So treat when necessary, not prematurely. We have a lots of food, it does not mean we should engulf them. Over treatment is better to avoid. To conclude with, precision means choosing when not to treat. In favorable intermediate risk prostate cancer, restraint may be the most precise form of treatment. At the most, you can keep focal therapy in your showcase as a middle ground between active surveillance and radical treatment for localized prostate cancer. Why I'm saying middle ground? When the patient is not comfortable for active surveillance or surgeon is not comfortable for doing radical therapy. Thank you. I'm little scared. Again, I show my humble apology that I am not physically present there, but at the hindsight, I feel I am okay to be away from my opponent. Thank you.
Can you hear me at the back?
Yes, sir. I can hear you, sir.
You can hear and we can hear you, but people from about 5th row are not able to hear. Huh? Thank you very much. Can you hear me at the back? Okay, thank you. So can I have my presentation? So that was an art of how to finish third in a 2-horse race. So the question was, how do we treat, whether it is radical prostatectomy or focal therapy, and he is going on about active surveillance. So that's what I will, let's see if I can make my point any more clear. I know, sir, that's the reason I'm saying. As urologists, the discussion is whether we should be doing radical prostatectomy or focal therapy, and he's talking on about active surveillance. So the medicine of urology. Thank you. So I'll talk about story of 2 cancers. And I'll start off from what he said, that we don't understand the biology. It is multifocality. Over-detection is a problem in prostate cancer, limitations of imaging, and we don't know what trial outcome. Should it be biochemical recurrence-free survival, or margin-negative surgery, or metastasis-free survival? But actually these parallels are there both for breast cancer as well as prostate cancer. And these are the 2 surgeons who heralded the surgery of radical prostatectomy and radical mastectomy, one for breast cancer and one for prostate cancer. Let's see what we can learn from breast cancer. What does natural history of prostate cancer teach us? When we say natural history, I'm going to quote a trial, the Protect trial, which was screen detected. These were not clinically detected, screen detected prostate cancer. So almost 70% of them were low risk prostate cancer. 70% were low risk. I'm not talking about intermediate. I'm talking about low risk. What happens if you keep an eye on them? Active monitoring, not active surveillance, active monitoring. By around sixth year, 50% of them do end up needing radical treatment. Okay, so by 6th year, all patients who were screen detected end up needing radical treatment. So that's one take-home message. There is no difference in the cancer-specific survival at 15 years, but metastasis-free survival is better even in all low-risk and some intermediate-risk patients. So metastasis-free survival is better at 15 years. So if I'm quoting natural history, this is not natural history because these were screen-detected prostate cancer. Number needed to treat, if you see there, 9 need to have treatment to prevent 1 progression. So if I want to prevent 1 metastasis, I need to treat 9 patients. And when you look at actually the breast numbers, these numbers are better than breast screening and breast cancer. So nobody is asking a question, why are we screening for breast cancer? But we are asking a question because we are a bit more conscious people. Intermediate risk prostate cancer is not a homogeneous cancer. It's a heterogeneous cancer with a combination of PSA, Gleason score, or clinical staging. And these are or. There is no and in them. Now they have gone on to the favorable and unfavorable intermediate risk prostate cancer so that we can add and to it. But when you look at it, PSA as a determinant of cancer-specific survival, it isn't a marker. If you see the PSA of up to 50 doesn't make a difference. So that doesn't seem to be the determinant. Clinical stage, again, all the ones up to the organ confined, so up to T3B seems to be localized. Only the T4 is away. But Gleason score does matter. Anything that is intermediate, anything that is ISUP grade 3 does tend to matter, does tend to have an impact. So the PSA doesn't matter and the clinical stage doesn't matter, but ISUP grade does matter. So that's why we can't just say intermediate risk prostate cancer for active surveillance. Does intermediate risk prostate cancer need treatment? The numbers are small. This is again from the Protect trial. The numbers are small because this was never powered to look at the difference. But if you see the numbers as such, about half of the patients tend to have either metastasis or progression. And when you look at the mortality as such, the numbers are again small, but it is indicative that treating intermediate risk does make a difference. And this is a large SEER database numbers. If you see there, 15,000, 1,700, 8,000, 1,000 patients. And what it showed is we always say, 70-year-old patient with intermediate risk doesn't matter. It does matter. If you see there, somebody with 70 to 79 is twice at the risk of having a progression compared to somebody who is younger. And when you look at here, somebody with a PSA of more than 10 has got twice the risk of having a progression, and somebody with a biopsy grade group of 2 versus 1 has got 2.5 times more risk of having progression. So it does need treatment. So the question is not of whether we treat or not. The question is of what treatment. And that's where the focal therapy comes. Whether you want to freeze it, cook it, or you want to heat it up. It's up to you. Depends on what you like. And it has also come into the guidelines. So going back to the first story that I started off, when breast cancer started off, mastectomy was the standard of care. Whereas once somebody started doing trial, this is 2002 trial, lumpectomy versus total mastectomy versus lumpectomy plus radiation, no difference. And breast is similar to prostate cancer. It's a lifestyle related cancer. It's a hormonal cancer. It is in a fatty area, but it doesn't seem to make a difference. And when you look at how breast has progressed from 1925 to 1990, accepting focal therapy, that's where we are with respect to focal therapy for prostate cancer, and we will reach there once we have got some more RCT evidence. Everybody points a finger initially when somebody questions what we know of, but that's where we are going to go. So the question is not whether we treat or not, which is active surveillance or treatment. The question is of how to treat it, whether it's a radical prostatectomy or focal therapy. And that's the reason I said it's third in the two-horse race, active surveillance. Thank you.
Dr. Sureka, you want to have a couple of slides on the rebuttal? Dr. Sureka? Yeah. Dr. Sureka? Dr. Sanjay Sureka, are you with us? Dr. Sanjay, you're able to hear me?
Sanjay, can you hear us?
Dr. Sanjay Sureka? Srivatsa, you want to have some comments from the house? Yeah, couple of comments on both the speakers. Anybody wants to?
It was a question asked before also. Everyone talks active surveillance. Who does active surveillance? I mean, 100 patients, 10, 20, 30 patients. Dr. N.P. Gupta has another 100 patients. Nobody really does.
When the question was asked before, sir, when we say active surveillance, in India it's always active surveillance stroke watchful wait. We are not sure whether the patient can withstand a treatment or does it deserve a treatment. So in India it's always about active surveillance stroke watchful wait. That's one. And second is, in the Protect trial, with so much of counseling, 50% of the patients by 6 years ended up having radical treatment, and the commonest reason was they could not deal with the fact that they had a cancer. It wasn't about the progression. So if that is what is happening with so much of psychological counseling and supporting and buttress, to do it in Indian setting is a lot more difficult.
Sir, my small experience with active surveillance is whenever the PSA rises in the next visit, like 3 months, 6 months or 9 months later, patient is not even ready for a repeat biopsy. He just says, get me a radical treatment. Means even if you tell him that we'll go for a repeat biopsy and understand is the progression in the Gleason score, they are not willing.
And I would add one point, because I do focal therapy. Post focal therapy, active surveillance comes in again, because you have left the untreated prostate there benign, which in 15% cases will make another cancer. So you need to be confident yourself first how you do it, and then explain to the patient, you're not going to die from that cancer. We will find it, we will treat it in time, and the odds are only 15%. So what I want to say is that you need to be experienced in all modalities to be offering the best standard of care.
I'll just make a comment. I think the key is in counseling. If your counseling has been good, majority of our patients are actually willing to explore active surveillance. The challenge is the long-term follow-up. Timely follow-up is the challenge, and many of the especially elderly patients are quite okay to follow up and then try and see if they can actually avoid a treatment. So I think we'll have to just open up. It's not because we do active surveillance and not focal therapy. What I'm trying to tell you is, we'll have to really look at it as a very key armamentarium in our treatment strategy. Then what happens is we invest a lot of time into it, counsel the patients, and then definitely a lot more patients can be recruited into it.
I think Dr. Sanjay Sureka is back online. Can you hear me?
Ramesh, 1 minute.
I'm online only. Just have a couple of minutes for a rebuttal if you have any.
No, I don't have any rebuttal. I thought it is only one-time presentation.
All right.
But what Dr. Shiva said, that nowadays a lot of patients who are well educated are coming for active surveillance from their own end, reading the chat GPT and all the information they have. And they know that active surveillance is a treatment model, they understand it. So in a well-counseled patient, because anyhow we have to do surveillance after focal therapy. So again that dilemma will come after focal therapy, that this patient may require, when you counsel for focal therapy, they understand that they may require additional therapy or radical therapy on longer term. So in our scenario, in well-selected patients, active surveillances are doing really good of late, of last 5 years. Before that, active surveillance was difficult and challenging. So this is what I believe and I practice.
So as long as biopsy is part of active surveillance, I think a lot of patients will not be able to follow it up.
I don't know whether biopsy should be a part of.
But it is now.
We don't know is the answer, sir. And I'm standing on the podium and I'm telling you that we don't know. The reason why I'm saying that is active surveillance, when it was designed in that way, we did not trust the MRI scan. Whereas now MRI scan is so much more robust and we tend to trust it. That's the reason in the Protect trial, they started off as active surveillance, they moved on to active monitoring. Active monitoring is what you do in your practice, what you think is acceptable. There is no agreed protocol as of now to say that this is what you should be doing. There isn't any biopsy, so that's what I'm saying. Even we used to do a biopsy of year 1, 3, 5 and 7. And then they said, the idiot is not a person who repeats the same question. Idiot is a person who repeats the same question and expects a different answer. So, and that was Freddie Hamdy telling us, saying that we were doing biopsies at year 1, 3, 5 and 7 and we expected different results. You do the same 12 core biopsies, why do you expect different results? Unless you said, oh, I'll do an MRI scan, I'll do a targeted biopsy. Last time I did a truss biopsy, I'll do a transperineal biopsy, I'll do a real-time fusion. Something has to change. If we keep on asking the same question and say, let's see if something changes, that is not a protocol.
So in this regard, as Dr. Sanjay said, that now there are lots of institutes following their own protocols. The most adapted protocol in our institute is what UCLA is following. So they are doing MR guided protocol or MR integrated active surveillance protocol. So only when there are definitive disease progression on MRI in either in pilot setting or in size of the lesion, they go for repeat biopsy, and they also include the PSA density and other markers. And then only the biopsy is being added in that protocol.
And Srivatsa, in your risk stratification, do you just go by the PSA, Gleason score, MRI, or would you also do IHC, genetic tests, family history, all that before you put them into an active surveillance?
Ideally, yes. It's an integrated protocol. When we started, we were just looking at these markers, PSA and the Gleason score and the number of core length positive, the core length involvement, so on and so forth. Now we have expanded our selection criteria. We are more careful. Even if there is a slight doubt, one cribriform gland reported in the pathology, we go ahead and do an IHC. And in patients with a family history of cluster cancers like ovary, breast, colon and all, we are very careful. We do not encourage unless the patient is relatively on the older side, and like Dr. Sanjay said, club it with watchful waiting eventually. But MRI is the key, sir. So right now, the MRI is the key, and we keep following them up very closely with MRI. We use the precise criteria. We don't just look at the pyrites. We have changed over to the precise criteria. We look at the change in the nodule characteristics. We biopsy only if indicated, and otherwise we just keep them on routine follow-up.
Sanjay, Dr. Sanjay Adla, your perspectives on a patient who is young, say 50 or early 60s, your threshold for active surveillance versus focal therapy?
The biggest problem I have is the mental capability to deal with the cancer, sir. So all the active surveillance who are continuing to be on active surveillance, it's like walking, whatever amount of time you spend, They just demand more time. So if they are able to deal with it in a matter-of-factly way and say that you do not need treatment as of March 2026, come back to me in 3 months' time and I'll tell you whether you need treatment or not. If they deal with it on that kind of a basis, quite often patients in my prostate cancer doesn't need treatment. No, that isn't the answer. The answer is in March 2026, your prostate cancer doesn't need treatment. We'll reassess you in 3 months' time, 6 months' time. We'll ask the same question. So for me, the biggest determinant is the mental capability of the patient to deal with the news.
So age is not...
Age is not that big an issue for me.
And sir, Srivatsa sir, can I ask one last question? So when you, in your integrated protocol, how do you decide the risk of dying from non-cancer? So in UK, what we do is we calculate the risk of dying from cancer and non-cancer. So for non-cancer, we use Predict database, which has list of comorbidities. You tick the box, it will give you a bar graph saying 90% heart-related death, 1% cancer death, or whatever. You also have frailty and risk, geriatric. Do you use any?
We use the Charlson comorbidity index and the frailty index. Yeah.
The last one, for using MRI, AI for MRI scan, we started using the Siemens one. It overestimates everything. So when I could see a lesion, a 1 centimeter lesion in the left half of the prostate, the AI would say the whole of the left side of the prostate is abnormal, just because I think none of these have been trained on Indian prostates. So unless we get Indian specific AI ability to report on the MRI of the prostate, I don't think we can just trust them and say that, okay, let's see what the progression the AI says.
All right. So it's always interesting to listen to a debate midway through a session. Would we like to have a show of hands, Srivatsa? You want to run and see how many are opting for active surveillance and how many want to look at focal therapy? Active surveillance for this profile of patient?
Average age of the people who have lifted their hand for AIDS, active surveillance.
That's why the question of age came up. All right. Thank you both for an interesting debate.
I request the chairpersons.
Thank you, sir. Just I want to add one point that chairperson was inquiring about the addition of other modalities. We don't have other modality, but if you see the recent dynamic integrated approach, they also add that prefer and other genetic modality to identify those patients who are at risk. Thank you.
Thank you very much to both the speakers and the chairpersons. I request the chairpersons to kindly give a token of appreciation to our speakers.
And we'll post it to other Sanjay.
I request Dr. Giri sir to kindly hand over a token of appreciation to Dr. Ramesh, please.
We have now completed the first scientific segment of the morning. We will now move on to the inaugural ceremony of UROVERSE 2026. So we begin with seeking the blessings of Almighty. I invite Dr. Preeti to render the invocation song.
Saraswati Vidhiyuvati Saraswati Vidhiyuvati Samrakshatu Mam Shri Saraswati Vidhiyuvati Samrakshatu Mam Shri Saraswati Vidhiyuvati Murali Veena Gana Vinodini Samvedini Murali Rasiruhalochani Murari Guru Guha Modini Shabdartha Swarupini Hamsini Brahmani Arakta Varna Rupini सरस्वती विधियुवती संरक्षतु मां श्री सरस्वती विधियुवती.
Lighting the ceremonial lamp symbolizes the triumph over knowledge, over ignorance. So may I invite Dr. B. S. Srinath, Dr. Patrikondaya, Dr. Rekha, Dr. G. K. Venkatesh, Dr. Ratkal and Dr. Prakash Prabhu to come forward and light the lamp.
ಪೂಜೆನೂ ಮಾಡ್ತೀವಿ ಬಂದ್ಬಿಟ್ಟು ಈ ಪಾಪ ಬಂದ್ಬಿಟ್ಟು ಅಂತ 15 ಡೇಸ್ಗೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಬೇಕು ಜಾಸ್ತಿ ತಿಂಗಳಲ್ಲೇ ಸ್ಟಾರ್ಟ್ ಮಾಡಬೇಕು ನಮ್ಮ ಬರ್ಕೊಳ್ಳಿ ಅಂತ ಹೇಳ್ತಿದ್ದೇನೆ ಇನ್ನೂ ಬಂದಿಲ್ಲ.
Very good morning, and I consider it my distinct privilege and honor to invite you all and welcome you all to UROVERSE 2026 on behalf of Sri Shankara Cancer Hospital and Research Center. Knowledge is, we all know, the most powerful protector of all of the entire mankind as well as the civilization at large. It has been told time and again over centuries that nothing can replace knowledge, and it has been very aptly and very succinctly communicated to us by Lord Krishna as well in Bhagavad Gita, where he says, Nahi gnanina sadrisham pavitram iha vidyate. So there are a lot of CMEs happening like this, lot of academic activities which continue to keep happening like this, and there is always a question as to why one more. So I think knowledge is rapidly evolving, and therefore it makes it very relevant for every single scientific activity which we need to participate in and absorb. So in particular, in today's context, I think we are at an era where one size fits all kind of treatment strategy is slowly giving way to more precision-based, personalized care, integrating multidisciplinary approaches, and the very objective of UROVERSE 2026 is to integrate all these multidisciplinary teams and discuss what the advances are that are shaping the way we treat patients with prostate and bladder cancer in particular. I take this opportunity to thank Srinath sir and also welcome him for UROVERSE 2026. Sir, this would not have been possible without your guidance and inspiration, sir. Truly, you are a big guiding force for all of us. Thank you, sir. I would now like to welcome all the faculty who have accepted our request to come, sparing themselves from their busy work schedules and most of them burning the midnight oil, as we could see in the mail yesterday, where they were fine-tuning their PPTs and sending it to us in the midnight. So that itself shows the kind of commitment, that you all have to furthering the knowledge. Thank you very much. I would also like to now welcome all the senior faculty, respected colleagues, who have likewise taken time off their busy clinical work and chosen to spend a day with us, trying to learn what's new in management of prostate and bladder cancers. With this, I now request Srinath sir to come over and give his inaugural address.
Thank you, sir.
very much.
A towering and inspirational figure behind this institution, Dr. B.S. Srinath, sir, a distinguished surgical oncologist, academician, visionary founder and managing trustee of Sri Shankara Cancer Hospital, Bangalore. His commitment to education, mentorship and innovation has helped shape a vibrant community of doctors. It's a great honor to invite Dr. B.S. Srinath, sir, for the inaugural address.
ಹಿಂದ್ಗಡೆ ಲೈಟ್ ಹಾಕೋಕ್ಕೆ ಕೇಳಲ್ಲ ಹಿಂದ್ಗಡೆ ಇಲ್ಲದ Good morning. On behalf of the trustees and the core committee members of Sri Shankara Cancer Foundation, let me heartily welcome all of you to Shankara Cancer Hospital. Dr. Srivatsa has taken a major challenge of packing too many things in one day. And we are already 20 minutes late, so I don't want to add to the challenge that he already has. I wish him all the success. Let him finish the program quickly. I have only two things to comment about. What you saw in this morning session so far is this. Basically, as is in all cancers, so is in urological cancer. Tumor is heterogeneous. There are multiple variable factors which are influencing the occurrence, the growth, the metastatic potential, and most importantly, the reasons for developing resistance to all the treatment that we are offering in all cancers, whether it is breast cancer, any hormone related or non-hormone related cancer, it is the same story. I think that is what we need to understand, basically. As we try to unravel more and more about this, we keep on running behind a shadow. And we always see something new coming up. And whether it is molecular pathology, genetic factors, these have added more challenges to whatever we understood before. Whoever thought 20, 30 years ago that we will be doing robotic radical prostatectomy? In Bangalore, there were very few surgeons who would do a radical prostatectomy 35 years ago. Now the things have changed. As we have adopted more and more technology and science is advanced, we have to see the news and information that is coming from our research and select the essential from that for add into our practice. That is where this CMEs come into picture. The second important thing is we have always been dependent on the information that is published in international literature. As now we are realizing that all of that may not really be suitable for our own Indian population. The stories are going to be slightly divergent. Somewhere Indian cancer scenario is different. We have cancer coming at an younger age, higher risk factors, and hardly 64% of our cancer patients are cured. And we already have 15 lakh cancer patients coming every year amidst us. It's a major challenge. And in 20 years, it's going to be 2.8 28 lakhs or 30 lakhs people. And still, the survival rate will continue to remain the same. Now, our challenge should be to pick them early, treat them, and wherever it is possible, prevent them. I think in this respect, my own thought is that we need to do much more amidst the society on one side, and then continue to explore the research path for finding a solution for cancer. One of the most important things is to have accurate data. The India will succeed only when we have truly accurate data, which means each one of us must document everything about the patients, both images, pathological reports, molecular reports, as well as our own clinical data, so that we can analyze them properly and use it for AI, for artificial intelligence, for a better prediction for tomorrow. I think that we are actually lacking far behind. Let me tell you our own story. We have treated more than 1 lakh patients in this hospital in the last 10 years. And when we try to analyze these case file documents to see whether they fit into any research study where we can analyze, the data was deficient in more than 40% of the case files. So now how can you depend on such kind of data? If you provide into the AI, what are you going to get? So I think the first essential thing should be to have accurate data documentation. Second, involve ourselves in research. I suggest the Urological Society in Bangalore starts a multicentric study within Bangalore itself, if it is not possible elsewhere. There are so many senior urologists here doing all this work. Document properly and create a database which can be properly analyzed. At least for the future, it will be very valuable. And I think going forward, technology will drive the entire treatment. Whether you like it or not, whether it is tools such as UroNav or a proper MRI or MR guided biopsies or molecular studies that we are going to. Whatever we thought before, the characterization of the tumor is being classified in a different way using the molecular pathology standards. Now they are completely different from our traditional histopathology. So the tumor classification is going to change. New additions characters are going to be added into it, so that at least we understand the tumor behavior properly, so that the treatment options can be done accurately. The second important thing that I come to is this. The younger generation of surgeons, whether they are surgical oncologists or urologists or uro-oncologists, they have a challenge. Technology is advancing, so everyone looks at robotic surgery, laparoscopic surgery, but hand skills are just gradually fading away. But the challenges are always there, and that is where the teachers of today will have to train the postgraduates properly in first developing good hand skills and doing good open surgery before they jump on to the laparoscopic or robotic surgery. Because that is where they understand how to deal the complications. Complications can happen to anybody. But how to deal with the complications is only known when you do it yourself. And particularly if they have the guides, teachers, they will learn by themselves. Otherwise, if they go alone into the practice, then I think they will face many challenges. So I don't want to take more time. I think the whole topics are so scintillating. They are very interesting. I enjoyed hearing the discussions all along till from morning. I wish all of you an excellent day particularly for the students, an excellent day of learning. And once again, welcome you to Shankara Cancer Hospital. Thank you very much.
Thank you very much, sir, for your inspiring words. One of the most anticipated parts of any surgical conference is seeing the experts demonstrate their techniques. So we request Dr. Raghunath S.K., Senior Consultant Urologist, HCG Bangalore, Dr. Prashant Kulkarni, Senior Consultant Urologist, NH Bangalore, and Dr. Rakesh Sharma, Senior Consultant Urologist, BIA CHRC Bengaluru, to chair the session and come over to the dais for the same. Today's semi-live surgical session will showcase advanced prostatectomy techniques designed to optimize oncological outcomes while preserving function. The first presentation will demonstrate the hood technique and neuro-safe approach strategies that aim to maximize nerve preservation. I invite Dr. Kinju Adhikari, Consultant Uro-Oncologist, HCG Bangalore, who also happens to be the first lady urologist of Nepal, to begin the session.
Good morning. In the outset, I'd like to thank Srivatsa sir for the kind invitation. Let us move forward from active surveillance to and focal therapy to how best we can do the surgery and still preserve quality of life to the patient. I'll be discussing on hood technique and neurosafe technique on robot-assisted radical prostatectomy. So what is the need? Why are we discussing all of these? Because we've already achieved the cancer control in terms of using radical prostatectomy, using robotics, and giving a very good perioperative morbidity to the patient. All this we have achieved. But what we still have not achieved, I feel, is the early continence. I'm not discussing about continence that we could achieve after 3 or 6 months of radical prostatectomy. I'm discussing on continence that we can achieve in weeks of radical prostatectomy, probably in days of radical prostatectomy. So there has been many refinements of surgical techniques and so many other parameters that could play in the role of maintaining continence. But before that, I would like to just highlight on what are the orchestra that interplay between maintaining continence of a patient. There are groups of muscles, all smooth muscles, voluntary muscles, which are anchored and fixed to pubic symphysis, ligament like puboprostatic ligaments, arcuate tendinous, and I feel the more important ones is the soft tissue or the fascial layer that would protect around and be around the urethral area. So lateral prostatic fascia, detrusor apron, intact innervation, which is one of the most important factor, angulation between the bladder neck and urethra, and the maximal urethral preservation. So these all play into the role on preserving continence of a patient. And I'll be discussing mainly about the hood technique, which was initially conceptualized in 2018 by Ashutosh Tiwari, and this was published in 2021, where the hood quite literally means the maintaining of the anterolateral structure of the in and around the urethra. So preserved tissue after prostate removal that has the appearance of hood, compromising the detrusor apron, arcus tendinous, puboprostatic ligament, anterior vessels, and some fibers of detrusor apron. So we can understand and see the hood that would be present after the surgery. So around 300 patients were evaluated here, and continence rates were also evaluated. The one thing that I noticed here is the surgical margin, which was somewhere around 6%. Here, neurosafe technique was also used, and these are the result. Week 1, 0 pad 20%. Week 2, 0 pad 36%. Week 4, 0 pad 83%. Quite encouraging outcome following this technique. So we need to understand before we go what exactly is the hood technique and why are we discussing about this, and what is other techniques that are anterior and posterior techniques. Hood technique is anterior approach where we go above the bladder and then try to preserve the structures around the in and around the prostatic ligaments and also around the urethra. This is a diagram which represents that. As compared to standard RARP and anterior technique, this is how we go. So the hood that we tend to preserve in the all those structures that I described before that we tend to preserve in the hood technique are not really preserved in the standard RARP. If we compare this with the posterior RARP, the residus sparing, we do not at all go to the anterior to the bladder, and everything is completed, the radical prostatectomy is completed posteriorly. So this is what is represented here, all the endopelvic fascia, the arcus tendineus, all the anterior and the lateral structures are all well preserved. And this is a nerve-sparing radical prostatectomy that was done in hood technique. The same was annotated in the MRI. In paucity of time, I'll just skip all this and just go to the video directly. So this is the video. Here we are starting with bladder drop in this video, but we have already completed the posterior dissection. We tend to like doing posterior dissection and peel off all the denon-villus fascia away from the prostate and go really near to the prostate capsule. Here we are dissecting the periprostatic fat away from the prostate, and we understand the bladder neck. Idea is to not excise the endopelvic fascia. So directly jumping onto the bladder neck and opening the bladder neck. So once we see the catheter, we pull the catheter superiorly and understand the bladder neck, proceed towards the posterior aspect of the bladder neck. Developing a retrotrigonal space when we are not doing a posterior dissection could be challenging in someone who might not have done posterior dissection so much. So once we find out the seminal vesicle and the vas difference, we catch hold of it and then try to create a plane that is most easiest. I feel the posterior plane, especially the midline plane, is the one of the easiest plane when to begin with, rather than directly going and jumping onto the lateral aspects and posterior lateral aspects. Once we get the plane, once we understand where the prostate capsule would be, and how we can separate the denon-villus fascia, then we can move on to more towards the lateral aspect. I feel if we understand, if we find one plane, we can just stick on to it and then follow it. So idea is to not use thermal energy as much. Try to clip the vessels. Even the stretch and the crush injuries could also cause neuropraxia. So the recovery of the nerve healing and everything would be detrimental here. Once we find the plane laterally, we peel off all the neurovascular structures away from it and then go anterolaterally. The difference here, the difference of hood technique and the regular nerve sparing technique would be when we go anteriorly, when we go anterior to the prostate, we tend to cut and go beyond the below the detrusor apron, and we do not go beyond more distally here. This is on the same thing on the left side, trying to peel off all the neurovascular bundles. Small vessels can be clipped, or even a point cauterization can be done. The plane might or might not be as easily visible or as easily understandable. Sometimes in a patient who has inflammation, the plane might not separate so easily as well. So once we reach here to the anterolateral aspect, or almost towards the anterior aspect, then we cut the detrusor apron and then we proceed distally. This is the DVC being cut. The key aspect of doing any nerve sparing surgery for that matter is to understand the apical area, because we would have preserved a lot of nerves proximally or posterolaterally. Apical area is the area where a lot of nerve comes and converges. This is the area where we are not really careful, we might transect those nerves. So apical area is very important, and for me I feel in radical prostatectomy, apical dissection is one of the most important part of the procedure. Here preserving maximal urethral length. So this is the completion, almost the completion of the hood technique, nerve-sparing radical prostatectomy. We have preserved a good prostatic capsule. There are no breach here. This forms the part 1 of hood technique. The part 2 of hood technique is the reconstruction of what we might have violated, especially the reconstruction of the arcus tendinous to the detrusor fiber muscles. So whatever near anatomical reconstruction that we can do, that we do in the second part of the hood technique. So this would be visible here. Here we are just repairing the bladder, and the posterior reconstruction is happening. Amniotic membrane, we tend to keep amniotic membrane if at all we have, if it is available, and the final reconstruction of the radical prostatectomy. So this is where we are not using nerve sparing. If we are thinking of doing a neurosafe technique, after radical prostatectomy, we remove the specimen. Specimen can be removed by either extension of the camera port, or we can use a different incision and use a gel port, and that specimen has to be sent to a pathology for intraoperative frozen section. So neurosafe means it is none other than intraoperative frozen section examination of neurovascular structure that is adjacent to the prostate. So this was first devised in the Martini Clinic in Germany. It's a comprehensive assessment of surgical margins adjacent to neurovascular tissue surface. So indication, I will not go more into it, but neurosafe, it is important for a pathologist to come and stay in the intraoperative area or in the operation theatre area for their understanding and alignment of the anatomy of the neurovascular structure and where we would want them to particularly see. Anyone who has intraoperative frozen section can do it, and a surgeon who is able to perform neurovascular nerve-sparing surgery can do this neurosafe technique. Once we remove the specimen has to be marked, inked differentially on the both side. So this has to be done by pathologists in coordination with the surgeons. I feel like having a pathologist in the theatre would help that, and after we mark it, the pathologists are able to align with our understanding of neurovascular structure and where they have to give us a positive margin and where we need to go back again and again re-excise so that margin comes negative after the second frozen section. So once we marked it, neurovascular adjacent surface is sectioned in about 4 millimeter thick slides. The tissue sections are mounted on cryostamps at minus 25 degrees centigrade, and a very thin, almost about 6 micrometer cross section are prepared from each block using microtome machine and mounted on a slide, and it would be visualized by a expert genitourinary pathologist. So this is a video of the same thing. Once we extract the specimen, it has been marked differentially with a different ink on the right and left side, and the slices are made, which is almost around 4 millimeter slice, and it is kept in a cryo mount and frozen at about minus 25 degrees centigrade after it is being fixed. So this is the slices being fixed, and now it will be in the freezer. After that, minus 6 micrometer of microtome or thin slices have been made, and then this has to be evaluated by the pathologist. We are fortunate to have a very good uro-onco pathologist in our hospital who gives us a very prompt and efficient report. So once the margin are conveyed to us, it depends whether the margin, if the margin is negative, we can go ahead with the reconstruction and do the anastomosis. If the margin is positive, we have to excise that particular area of the neurovascular bundle and then do it until it is negative. So this is our paper that we have published about the same, where we looked into the technique feasibility and early outcomes of NeuroSafe, where we evaluated few of our patients and found that frozen section margin, all of them had negative frozen section margin. It was 100% concordant in the final histopathology as well. 6-week morning erection was present in all our patients, and few of our patients had not taken PDE5 inhibitor, but maximum patient had taken PDE5 inhibitor. One more thing I would like to highlight here is on the addition of the armamentarium that we have in terms of how we do the surgeries. This is a DTI technique where we can outline the nerve fiber tract and create a 3D model. So diffusion tensor imaging is a new MRI modality born in the field of neuroimaging. So neurosurgeons regularly use it. They regularly see it, the nerve fiber tract, and that's how they do it. So this is what we have incorporated in urology as well. And this is the kind of 3D model that comes up where we can understand the relationship of the nerve fiber tract in relation with the prostate, in relationship with the disease as well. So we would have a 3D imaging, some idea before we go and operate. It also is useful to educate the patient regarding where the tumor, where the disease is, and also helps in training as well. So this is another picture where we can see the round left side disease and its relationship with the tumor nerve fiber tracts. Concordance with final histopathology somewhere comes around 95 to 100%. In our series there was 100%, but our number was little less. It was 6 patients. In terms of whether we are actually compromising the oncological outcome, because that is our number one factor in the trifecta. This is a paper which showed that NeuroSafe did not have a negative outcome on BCR, especially on T2 patients. The curve is not really diverging at all here. But even in the patient where the surgical margins are positive intraoperatively, these patients also did not differ significantly those who had primarily negative surgical margins. NeuroProof is a phase 3 trial which was done to understand NeuroSafe RARP versus standard RARP and the recovering of the neuropraxia. We can see over the month, 3 months, 6 months, 12 months, NeuroSafe patients had a better recovery as compared to non-NeuroSafe patients. Here PSA persistence was 4% in NeuroSafe patients versus the 3% in standard RARP, as compared to also biochemical recurrence 6% versus 4%. To conclude, radical prostatectomy is not just about removing cancer, but also preserving function and quality of life. Hood technique preserves the periurethral continence apparatus, facilitating early return of continence. NeuroSafe allows confident nerve sparing through intraoperative margin assessment, and together with all these techniques, we can help achieve the trifecta of cancer surgery. Thank you.
Kinju, what I saw in the video is the standard hood technique says that the DVC is not cut, but I saw you cutting the DVC. Any reason for that?
Sir, even in the Ashutosh Tiwari's series also, the initial one series also, when we are going just below the datachrome, ideally we do not encounter so many vessels. But if we are slightly distal to that, we tend to encounter DVC vessel. A few veins would be there where we can intraoperative preemptively like it.
Dr. Kinju here. So, how standardized is this NeuroSafe, and how can you correlate your technique intraoperatively with the 3D model that you, because see, we are all used to 3D model building in, say, for example, nephron sparing surgeries. So, what kind of a correlation can you, because I'm sure you have used both. So how do you rate the 3D modeling in prostate?
So this is very new to us also. We are, it's been few months only that we have started. We are in the process to validate it. We have not yet validated it fully.
What is your gut feeling?
It is good. It is good. So what our understanding initially was, and the classical teaching initially was, the nerve fibers that would run around the prostate would be moreover 60-70% moreover would be the posterolateral area. With our understanding of 3D, we intend to find out that some nerve fiber tracts are in the anterior, especially anterolateral areas also. So these kind of insight we are getting, and also it is helpful for us to understand the location of the disease in terms of rather than understanding and seeing in the MRI and trying to form a 3D in our mind, we can directly see a 3D and operate. So that is one, and also training and understanding of the patients that I feel is helpful.
A couple of comments. Yeah, we are doing 3D for the first time, not just 3D of the prostate, similar to 3D of the kidney. It is DTI acquiring the neurovascular bundle is a separate process. There is a separate protocol for that, and you develop 3D of the neurovascular bundle separately and 3D of the prostate separately. There is a special software to integrate both into 3D of one. Whatever you have seen is the one 3D of the prostate along with the 3D of the neurovascular bundle. That overlay is very, very complex. Okay, so that we are doing. We are in the process of validating. We have done for more than 40 cases we have done so far.
Any differential way of acquiring MRI images for this? Are there any specific requirements?
No, almost all modern MRIs will have DTI protocol. DTI is inbuilt into the MRI. But acquiring that and process is different. Processing that image, once you get the DICOM images, how you are going to process, that requires special software. That is not available.
So there are no, like how we talked about acquiring 3 mm, 2 mm thickness slices for navigated biopsy. There is no such additional or differential protocol that you...
No, there is a special protocol. There is a special protocol we have installed into our radiology department. Okay. With that only you can do it. Not regularly, even if DTA is there, without that protocol, if you get it, we cannot process that.
NeuroSafe, one last question. Okay. With NeuroSafe, first thing, how much time it takes additional time to wait? Question number one. Question number two is, if one margin is positive on any side, anywhere, is how easy it is to go back, locate it and take out that area. So what is the decision making? Are you going to completely take away the nerves on that side? These are the 3 questions.
Yeah. So number one, it generally takes around 20-25 minutes, but it all depends upon the pathologist again. That is what we have observed. 25 minutes is the time. I'm not counting the time of painting and then sending. Just for the pathologist, to create that slide, it takes 25 minutes and to give us the report. Second thing, surgical margin, if at all, if it comes positive, this is where I focused on why the pathologist has to remain in the theater to understand the orientation of the prostate. And we generally, how we communicate with our pathologist is we specifically tell them this is the disease in the prostate. Intraoperatively, they will see in the screen, and also while painting also they would be seeing. So understanding and the alignment of the surgeon and the pathologist comes into play. That is second thing. Third thing is, once the margins are positive, there are 2 options. One, we can go ahead and excise the particular area where the margins are positive and then again send it until the frozen section is negative. That is number 1. Second thing is, it all depends upon how we counsel the patient. If we have counseled the patient in terms of removing the neurovascular bundles, if at all it is positive, then we can excise it.
Now you have confocal laser microscope available. With that, probably the speed of the process can be faster.
Wonderful presentation, doctor. Do you select patients for NeuroSafe, or you submit every patient for NeuroSafe?
So NeuroSafe technique, I think I missed this in my presentation. NeuroSafe technique is a technique that can be adopted even in open lab robotic surgery. For nerve sparing, we select how we select any other nerve sparing patients.
Thank you, ma'am, for the excellent surgical demonstration. We now request the chairperson to hand over a token of appreciation to ma'am. The Redshift sparing approach represents a significant innovation in prostatectomy. To walk us through this technique, we invite Dr. Srivatsa N, Senior Consultant Uro-Oncologist of Sri Shankara Cancer Hospital.
Good afternoon. And prostate is an enigma. There are several approaches to do a prostatectomy. Now we are still debating whether we should do a prostatectomy or not, and then as you move forward, you will also start seeing that there are so many ways to do a prostatectomy. It could be an anterior approach, it could be a hybrid approach, it could be a hood Redshift sparing. So the bottom line is very clear that I don't think we have as yet arrived at the right technique, because the moment there is more than one technique probably to deal with a problem, we are still not sure what is the best way to deal with the problem. So we will have to kind of select patients and cater to them, their requirements, their disease in particular. But if somebody asked me whether if there is one technique that is probably a reasonably good way to deal with most prostate cancers requiring radical prostatectomy, I would vouch for the Regia sparing prostatectomy. Regia sparing now was the original concept which was described by Galfano, and they have done thousands of cases, and I think now we have graduated from what is a Regia sparing technique to what we call as a true posterior approach. So like how we have the anterior approach to do a prostatectomy, I think Regia sparing should truly be called a posterior approach, and this is very important to understand because there is a strong misconception that in a Regia sparing prostatectomy you can't go very wide, you can't do a very radical surgery, and it is kind of not suitable for a locally advanced disease. So this is not true anymore, and in almost every single case, posterior approach sparing the Regia space can be utilized to do a radical prostatectomy. What are the key advantages? It preserves all anterior structures and it minimally disrupts the pelvic anatomy, and therefore will contribute to significant or early recovery of urinary incontinence. Like I mentioned, the anatomical rationale is, we don't cut the puboprostatic ligaments, we don't cut the endopelvic fascia, we don't cut the DVC, and we don't drop the anterior bladder attachments. And only after starting to do the Regia sparing prostatectomy, we realize that there is a nice hood. And probably Ash Tiwari started developing this concept after he saw the hood of the Regia sparing prostatectomy. So there is a nice hood which runs all the way from the bladder right onto the prostatic urethra, which anchors the prostatic urethral complex and significantly contributes to early recovery of urinary continence. These are the advantages. I will not go into great details. Immediate continence in many patients, close to 28% of them will have immediate continence. That is day zero continence. The moment we remove catheter, they are continent. And in about 8 weeks' time, close to 90% of them would be either continent or on a protective pad. Only few patients go on to leak for longer, and this is probably the main advantage of Regia sparing prostatectomy. And likewise, Regia sparing prostatectomy is equally effective in preserving the neurovascular bundle, the two cardinal functional outcomes that we assess during a radical prostatectomy. But it has been challenged for a long time by most of the opponents, I would say. They would say that there are higher positive surgical margin rates, especially anteriorly, where we need to drop the bladder, prostate from the bladder attachment, and therefore a higher risk of biochemical recurrence and eventually inferior cancer control. But most of the recent papers are showing equivalent oncological outcomes. What are the challenges? I think it has a steep learning curve, because you are literally looking up to do the operation while most of us are used to looking down to do the surgery. So you will have to look the inverse way to do this surgery, and probably in a limited working space. So I will not go with the full video. I will just show you a few critical steps of how we do the Regia sparing prostatectomy. So this is how we deal with the pedicles. This is a typical posterior approach, and every time we have to do this. So this is how we approach. We are now creating a plane. This is a non-nerve sparing technique. I'll show you nerve sparing later. We create a plane between the rectum and the pelvic wall till we see the endopelvic fascia. It is largely a avascular plane. We go lateral to the apex of the seminal vesicle, again down to the endopelvic fascia, which effectively creates the entire prostatic pedicle. So this is an approach that we have now standardized in our workflow. So we do not struggle to identify the pedicle at all most of the times, especially when we do a non-nerve sparing prostatectomy. You can see that that's the prostatic pedicle. All it requires is one clip. So you can see the endopelvic fascia and the prostate almost lifted up once this pedicle is controlled. The next, yeah. Sorry for this. Yeah. Idella, bladder neck. So next is the bladder neck dissection. Yeah. One thing that we realized after starting to do the radius sparing prostatectomy is that there is a distinct bladder neck, and this bladder neck is a tube. Oh, this is not the video. Yeah, 1 second. Yeah, I'll just. So this is we have kept the camera 30 up, and we have started to mobilize the base of the bladder, and you will see that that is the typical bladder neck that we get during a radius sparing prostatectomy. We hardly have to reconstruct the bladder neck. See, you can see that. We hardly have to reconstruct the bladder neck in a well done radius sparing prostatectomy. Oh, 1 second, this bladder neck to apical dissection. The next critical element in recovery of continence is the apical dissection. So here you can see very well that laser is there. This is the detrusor hood, which we are not disrupting at all. This is the detrusor hood which is coming from the bladder going right onto the prostatic urethra, and we are working in a plane between that and the prostate. And to minimize the risk of anterior margin positives, what we have done is kept a thin sliver of the detrusor muscle on the prostate there. And this significantly reduces the risk of margin positivity rates, which is one of the challenges with radius sparing prostatectomy. And if you are in the right plane, you can see that we are cutting the detrusor there. If you are in the right plane, then you don't really need to cut the DVC at all. The DVC remains posterior or inferior to this. So once the whole complex is dissected, you get extraordinarily good urethral length, and we need to understand that this is the kind of urethral length that is much more proximal to what we see when we cut the DVC. So we have not cut the DVC at all. So we are literally at the ureteroprostatic junction, and you will actually see the verumontanum. Yeah, there you can see the verumontanum here. That's what I'm trying to show there. That's the verumontanum. So the kind of length, the urethral length that we get is probably maximal in the radius sparing approach. And not only that, the entire anterior urethral complex remained intact. Now I will just show complete intrafacial dissection that can be done using the radius technique for neurovascular bundle preservation and preservation of erectile function. So we go completely intrafacially, but of course this is in a very highly selected patient, obviously, where the posterior dissection is very typical to a posterior approach, like how it is conventionally done. And in a well done intrafacial dissection, we probably don't need to apply even one single clip. So you will now see that the entire prostate is lifted up. Once that's done, we start contouring laterally just on the prostate. And this is one instance where we use a Maryland forceps, because our workhorse is a fenestrated bipolar. Only when we do an intrafacial dissection, we use the finer Maryland forceps. And now you will see that the entire veil of Aphrodite is completely preserved. We have not seen the neurovascular bundle at all. We are just on the prostate, and the entire veil is preserved intact, along with the anterior prostatic anterior urethral complex. So the whole dissection can be complete with a 30 up camera. You will see that the DVC is behind, and we are working right at the apex. And what I am peeling now is the detrusor fibers and not the prostate. The other challenge that radius sparing median lobe poses is in difficult situations. The difficult situations being presence of a large median lobe, post TURP status, or in a patient who has undergone prior surgery. It is actually converse that a median lobe is typically posterior, and therefore with a posterior approach we can very easily see the median lobe, and even when median lobe is present, in majority of the cases we can actually have a very minimally opened bladder neck, which probably does not require reconstruction, which is a consistent requirement when we do a anterior approach prostatectomy. You will see that there. You can see the median lobe here. Now, yeah, that's the bladder neck. So you will see that there, and then you will see that we are able to deliver the median lobe away from the bladder neck, because the median lobe is not involving the bladder neck. In an anterior approach, we need to cut through the posterior plate of the bladder wall to reach the median lobe. But here you can see that is the kind of urethral opening that we will get, and what you see here is the median lobe. So that's the eventual bladder neck that we got, even in the presence of a median lobe. Yeah. So radius sparing prostatectomy can, in selected patients, do very well, and in a trained hand, I think the outcomes are equivalent in terms of recovery of continence or recovery from erectile dysfunction, as similar to that of a hood technique. And in the contemporary series, we don't see as many anterior margin positives as we saw in the past. Thank you very much.
Dr. Srivatsa, congratulations, because you are the only few persons who can do this procedure, I think. First of all, to tell you, I have seen you operating this particular procedure. It looks easy, but it is not. It is very difficult to repeat this procedure. What do you feel that initially, how did you overcome difficulties for initial few cases, 5-10 cases?
Yeah, so our first radius sparing prostatectomy was accidental, sir. We were just doing a posterior dissection and we accidentally opened the bladder at the base. And therefore, we didn't know whether we would get that opening if we dropped the bladder, and therefore we completed the case using radius sparing technique. But over a period of time, what we realized is, I think all of us should start, and most of us do that actually. We do a hybrid approach. Nobody is doing a pure anterior approach, at least in a very few people do it. So combined hybrid approach where we do it posteriorly, try and dissect the posterior plane as down as possible to the apex of the prostate, and then control the pedicles laterally. Dropping the seminal vesicles and vas is pretty standard. Once this is done, I think it is all about two additional steps. One is contouring the prostate. The second one is dealing with the bladder neck. Once you have cut the bladder neck, it is pretty much the same again. So at least in somebody who wants to really explore this technique, I would recommend that they start doing the posterior dissection as much as possible, and then eventually when they try and reach the bladder neck, they can drop the bladder and then complete the procedure. It will probably take 10-15 cases, and then I think they should be through.
I think initially 30-degree up dissection, I think we should spend some time there posteriorly.
Yeah.
I think. Yeah, nice point. Thanks.
Just to comment, we sent our pre-prostatic fat separately. In almost 8 cases, though it is not described widely, lymph nodes were present. In that, 3 patients had positive lymph nodes, where we are not going to remove this.
No, so that's the point that I wanted to say, sir. I have just shown you some bits and pieces of prostatectomy. the Redzius approach can be adopted even for locally advanced prostate cancers, where we can cut the DVC and remove the anterior periprostatic fat as well, probably in a locally advanced case in a selected individual. That is why I kept telling that it should be promoted more as a posterior approach rather than a Redzius sparing. And the advantage, then why do it is the question. It is because even if I end up cutting the DVC and opening up the Redzius space from posteriorly, I would have I would not have disrupted the anterior pelvic anatomy.
Nowadays, many people started doing anterior Redzius sparing, where you are going to preserve all the attachments. It's easy. You have a more space, even residents, so you can train them very well. You preserve all the attachments going anteriorly. So it's called anterior Redzius sparing. You have any comments on?
That's exactly. So in Southampton, Tim Duttridge does this. So he will drop the bladder, then stitch it up again. Call it anterior Redzius.
So why drop it and stitch it again is the question.
So that's the thing. So because nobody knows how it really promotes early continence. One of the theories is the angulation of urethra, and if the bladder is slung up, it works. But what happens in that is, the another advantage which nobody talks about is there is 30% reduced future hernia risk because you don't disturb the endopelvic anatomy. So because you're not obliterating the myoperitoneal orifice with dissection, hence the future hernia risk goes down. So with the anterior reconstructed pseudo-Redzius, that doesn't happen. So his case came to me because I'm a hernia fellow as well. So patients move across trusts. And then he had a hernia case, and then he got stuck with that approach because the dissection becomes difficult when you try to do those things.
In fact, a few German surgeons have described, they don't drop the bladder completely.
Yes.
They keep it intact in the center. They go from laterally.
Yeah, Gaston, exactly. I think Richard Gaston does that. So lateral
same
access
thing. Yeah,
technique.
don't dissect the obliterated umbilical. Go from middle. Let them keep hanging. All those modifications.
Basically, whichever the approach, you preserve all the attachments, preserve maximum functional length, give oncological and functional outcomes. I mean that is the bottom line.
Yeah.
And post-transplant kidneys, Redzius spare works wonderfully. It works. Yeah.
So even technically speaking, the perineal radical prostatectomy is more anatomical than all these things. But why we are not doing it? It is the technique which was described in early 19th century. But we don't do that. It's very difficult to duplicate that. In fact, that is the one approach where you can do intraprostatic dissection of the urethra and you can preserve maximum functional length with that only. But we don't do that. It is possible to do even robotically, but we don't do that regularly.
And Srivatsa sir, the technique which you have standardized for going lateral to the pedicle first and then doing for extrafascial, I wish you had submitted that way because same technique was submitted in World Journal of Urology. I was the peer reviewer for it. And I was thinking, this is nothing. Why am I allowing this to get published? But then it was a big European name. I just could not say no. It was same as what you're doing.
Unfortunately, my colleagues, younger colleagues, don't think that it's a good step to highlight. But I can tell you, I can vouch for it. Manish is sitting next to you. He has himself done this. Literally 100% of the times, this technique works. Yeah. Literally 100% of the times, our pedicle control is over in less than 5 minutes.
Yeah, and he had written the same thing. You do this way, this technique this way, and you don't get anterior margins because you are above all the anterior DVC. You can just go swipe, and you can even take out fat and everything. He just published it. So.
Yeah. Yeah, so the space what we get is pretty much the same. If there is a challenge with the space, then you just keep going laterally onto the bladder pedicle. So you cut little laterally. In fact, of course, that is not a theme of the today's presentation. We can show you where we have gone right up to the ureter, traced the ureter entering the bladder, brought down all the structures from there. So the moment you start mobilizing more and more laterally, the space keeps opening up. So personally, if you ask me, after having done so many, I don't see a challenge of space at all.
That's what I wanted to ask. The risk of ureteral injury, because most of the dissection is posterior. The risk of ureteral injuries during this procedure.
Yeah. So we have injured ureters. We have cut ureters 3 times, sir, till now. So we have completely transected the ureter.
If you tell that, nobody will attempt.
No. So, I mean, I want to tell you, you should not give up. So now we have standardized the procedure. We exactly know where the ureters go. We look for them, we protect them and complete the dissection. Initially, yes, it will be a challenge, but I think the cardinal rule of not going lateral to the knuckle of the vas. If you don't go lateral to the knuckle of the vas, there is very less likely chance that you will, injure the ureter. Having said that, like I have admitted, we have cut the ureter thrice. Luckily, we have been able to identify at all times and reimplant them.
But initially there is a margin positivity is there when you start.
Yeah,
because I started 10-15 cases we had BCR, we had margin positivity, base side, apex side, which generally doesn't happen when you're doing an anterior approach. So again I came back to the anterior approach because that was very difficult.
No, you should, I mean, that's what I tell you. There are some, margin positivity mostly happens anteriorly because you are trying to disconnect the prostate from the bladder, and you tend, how you saw in the intrafacial dissection, you are literally working on the prostate. So, and with limited vision on that side, you may leave behind some prostatic tissue. But if you shave the detrusor is a very thick muscle. So that is the modification that we have adopted now.
I'm not talking about the anterior, even in the posterior lesions at the base.
No, I don't think so, Rakesh. Like maybe you do a little more, I think. Posteriorly, it's pretty much the same. That's what I feel.
No, at the base.
You would have either ways gotten it.
If you do anterior approach, anterior margins is not at all a problem because you have removed the prostate and there is nothing you are going to leave behind.
Exactly.
So,
to add to sir, because when I was training, Dr. Rawal was doing Redzier spare and he had just begun, and I only saw Redzier spare. So to me, anterior prostatectomy was difficult. Then I went to UK and then I learned the nuances of nerve spare from front, because for me, from behind it's natural. It's all about what you are used to. It's not a tough operation. To me, it feels more easier than an anterior prostatectomy.
And we save a lot of time, sir. That's what I can say.
Thank you very much, sir, for this enlightening video and the discussion that followed. To discuss strategies following that surgical perspective, we now look at optimizing outcomes through radiotherapy. And to discuss these strategies on enhancing functional outcomes using radiation therapy, we invite Dr. Pradeep Reddy, who is consultant radiation oncologist at Shankara Cancer Hospital.
Good afternoon. I would like to thank Dr. Srivatsa for giving me this opportunity. But actually this is functional outcomes, the word, we don't use it so frequently with radiotherapy. We may talk about organ preservation. We may say we prevent APRs, we prevent laryngectomies, but the difference between the toxicities or functional outcomes it's very thin. So I hope I would do justice to this topic. So just for introduction, we know that risk stratification becomes very important in prostate cancer, and I don't have to tell this crowd that how to manage each subset, so we'll move on. So the current day, the modern definition of cure and quality of life is the one which determines the success of the treatment or what treatment you want to take. So most of the treatment decisions are influenced by your side effect profile. We know that when there are two modalities which are going to give you the same care, so obviously patients are going to ask us, what is your side effect profile? Should I choose between surgery versus radiation? So your side effect profile is going to define what modality patient is going to choose. So the most common side effects that we encounter when we treat a prostate cancer, either with surgery or radiotherapy, it's all genitourinary, GI, and erectile dysfunction or sexual preservation is what is most of things. And if you want to avoid all these toxicities, best thing is to put him on active surveillance if that patient is, and we had enough debates about that, so I will not talk much about that. So I think surgeons have evolved with time because they started looking at strategies where to prevent or preserve the sexual function in prostate cancer. Similarly, I think radiotherapy has also evolved. So there are lots of developments in terms of delivery techniques or verification where we started using IMRTs and IGRTs. So our toxicity profiles have actually dramatically reduced. So we don't get to see the kind of proctitis what you are seeing probably 10 years or 20 years back. So toxicities have reduced. But if you specifically ask about the functional erectile dysfunction, so I think some trials or some studies have been done, but I don't think routinely they are practiced in our radiotherapy practice. So just looking at the functional outcomes reported in the literature, so you can see that this is comparison between prostatectomy and radiotherapy. So urinary incontinence is one, I think, which radiotherapy would never cause, and sexual function is one which increases over a period of time. So your erectile dysfunction, I think, as the time progresses, at 15 years, 93.9% of them had erectile dysfunctions. So looking at that, so probably you would. People started thinking, how can we do like surgeons? So people started to think like surgeons. So we know that erectile dysfunction, again, is a multifactorial thing. It's not that radiotherapy alone would cause or surgery alone would cause. Even patients who don't have prostate cancer has erectile dysfunctions. So when you look at patients who have received radiation and they had erectile dysfunction, so you need to have a properly functioning neuroendocrine axis. You need to preserve the nerves. You need to preserve the vascular pathways. And particularly after radiation, the arterial insufficiency is the one which has actually resulted in most of the erectile dysfunctions. So looking at that, people started looking at what are the probable ways that we can mitigate this side effect or probably can preserve the functions. So I think these are the neurovascular bundles which are very close, which are posterior lateral to the prostate and the internal pudendal artery where the blood supply is important, and even the vasculature of the penis. The penile bulb is the one which has been most commonly discussed in radiotherapy trials to reduce the toxicities, and even the corpus cavernosum. So these are the structures where they are trying to limit the radiation. But problem with all these things is most of the radiotherapy plans are planned on a CT scan, where identifying these structures would be very difficult. So though recommendations are to use MRI guided planning where you fuse a CT scan and MRI, but routine practice of MRI fusion for prostate cancer is difficult. So good anatomical delineation of structures where you can identify the vascular bundles, where you can identify the tumor, and is it possible to preserve the function as well as treat the tumor. So that becomes a challenge because most of the tumors where you have in the peripheral zone, so it will be very difficult to spare a neurovascular bundle where your tumor is sitting very right next to it. So obviously if your anatomy is good, so again these are the various factors that would determine the outcomes. If you have good anatomy where your artery is far away, where you have good length of urethra, prostatic urethra. So if anatomy is bad, so this is where I think all problems or patients would develop all these functional outcomes. So you can see here again, though you have an MRI, though you can contour better, again the anatomy is not going to be the same. So you have lots of variations. Your neurovascular bundles are not going to be the same in all patients. So it is very technically challenging for radiation oncologists to delineate all those nerves and vessels and try to spare them at the same time. So I think there was few phase 2 trials which have tried to spare, copying the surgeons. So we also started looking at vessel sparing radiotherapy. So it was a single arm phase 2 study done by Daniel Spratt. So they claim that they have actually erectile preservation rate was 70% at 2 years and 66% at 5 years. But again, problem with the trial is, so it is a single arm study which has its own sterility, but people have attempted. But unfortunately, the routine practice of this doesn't happen. So similarly, there are a few ongoing trials which are looking at trying to prevent. So there is one with Potency trial, so where it is comparing standard versus neurovascular sparing guided. The other one is the ERECT trial where they are using an MR guided LINAC to actually adapt radiotherapy. So MR guided LINAC has been little promising because again, the moment you have an MRI, your soft tissue delineation would be better. Probably you'll be able to identify the neurovascular structures, but adapting everything. So it has its own trials, but currently these are the two trials which are trying to look at prevent the erectile dysfunction. So the other common, I don't know, toxicities, should I talk or not, but if you look at the toxicity grade, so I think as the techniques of radiotherapy has evolved, so 3D CRT followed by AMRT and IGRT, the incidence of cystitis or grade 2, grade 3 toxicities have actually come down. So, I mean, I was not sure, so I will just skip. So there are other new things that what we are doing to prevent further more toxicities. Again, we are using something called as spacers. So because OAR or organ at risk for us to prevent the proctitis would be the rectum. So we are using something called as a spacer where you insert between the rectum and the prostate so that the dose would be sufficiently delivered to the prostate. At the same time, you don't cause much morbidity of the proctitis. So again, this is a phase 3 trial. So I think probably they showed that the primary outcome was to at least more than 70% of the patients would achieve a dose reduction to the rectum. So in the trial, so published data say that 98.5% who had undergone a spacer insertion, so they experienced 25% or greater reduction in the rectum dose, which is reaching more than 54 gray. And similarly, the 2.9% of the spacer group had lesser toxicities. So the both acute as well as late GI toxicities were less. So I think again routine practice of using spacers is not currently done. So I think again obviously it's anatomically if there is a gap between your OAR and prostate, so you're always going to spare lots of normal tissues and your toxicities and functional things are going to be better. So again, coming to MR-Linac, so MR-Linac has been very promising. So it's actually MR-Linac is nothing but we currently have a CT scan for the IGRT component. So MR-Linac would have an MR where you do an MR before delivering the treatment. So obviously MR can give you a better soft tissue delineation. So with MR, what can be done is other important OAR or whatever we could see is urethral strictures. So generally, I think again urethral strictures have been a big problem with prostate brachytherapy. So if implant doesn't come well, and if there is a needle very close to the urethra, so you end up having strictures where I think again with advent of MR guided radiotherapy or MR Linacs, so you will be able to identify the Linac and probably you can spare or you can optimize the radiation in such a way that your urethra does not get much of the radiation there and can probably improve the functional outcomes. So MR-Linac actually has demonstrated that there is approximately 3.3 Gray is less when compared to VMAT or tomotherapy because VMAT and tomotherapy would not have an MR guidance there. So probably they would have based their treatment on CT scan. It is difficult for you to identify an urethra on a CT scan. So because if once you can see, I think you can actually reduce the dose and probably you can decrease the stricture chances. So I mean, I am not talking much about the toxicities. So I would, to conclude, functional outcomes would actually determine how a patient would choose a choice. So probably if the side effect profile is better, probably they tend to do that. So erectile dysfunction has been more common with radiotherapy. So the alternative for that, people had come up with vessel sparing radiotherapy, but unfortunately it is not easy to practice, or it's possible, but I think you need still a lot more data to routinely practice on everyday practice. And more than data, it is actually the technicality or how well we can do that or deliver it is the challenge. And rectal spacers have actually further decreased the GI toxicity. The proctitis chances are further reduced with rectal spacers. And MR-Linac is probably, it is, again, I would say MR-Linac is not the best, but probably it is better than what a CT scan would do. Any questions?
Excellent presentation, sir. Sir, two questions.
Yes.
We all have as a urologist. One is proton. You're talking a lot about proton. So
Okay.
what is your take on proton and how it overall reduces the complexities and the problems to the patient, the side effects? Second question is, as we are doing the focal therapy, like Jiten mentioned that we are only the dominant nodule we are taking care of.
Correct.
Can we do a targeted radiation only to that dominant nodule and minimize the side effect, something very closer to active surveillance?
Yeah, so coming to protons, so protons are, in terms of physics, definitely they have an advantage. So whether that same advantage of physics, what you have, would it translate into a clinical benefit is still a question. So because again, it all depends on what volume you are going to treat, whether it could be a proton or it could be a photon. Eventually, we will be still treating an entire prostate plus some amount of seminal vesicles. So only thing is the dose pillage, what we say, the low dose pillage, probably 50%, 30% dose pillage. So that would be very less with prostate. But again, in prostate, when you are treating only prostate, okay, again, treating lymph nodes is a debatable thing. So if you are treating only prostate, your OAR would be a rectum and bladder, very close to that, probably neurovascular bundle. So I don't think neurovascular bundle sparing would be possible even with protons. Probably, yeah, your low dose pillage is what is that. So GI toxicity would be less. But as of now, there is nothing great data to show any difference between protons versus photons. So I think even in good hands, I think you can do a good amount of prevent lots of toxicities even with protons, because IGRT is the one which has actually changed rather than the whatever photon or proton. The other thing, I think whatever asking dominant nodule, I think the flame trial is the one which is looking at escalating the doses to the flame. So I think as of now, data is not so great, but yeah, obviously, but you will still treat the whole prostate. So it's not that you are not treating the whole prostate and treating only the dominant nodule. Some amount of dose still goes to the whole prostate. Only the dominant nodule, probably they will escalate the dose to higher doses. So I think probably, data is still required to say that we can figure out a proton is better or even you want to treat only the local nodule.
Thank you, sir. Any questions from the audience?
Thank you, sir. We now request the chairperson to hand over a token of appreciation to the speaker. Is that right? We now request Dr. Venkatesh Krishnamurthy to hand over the memento to the chairpersons. Now we move on to the session on expert comments. So due to lack of time, one critical comment each we would about the session. Yes. Yes, sir. So if there is nothing, we will move on to the next academic session, chaired by Dr. A. Mohan, HOD Urologist of St. John's Medical College, and Dr. G.K. Venkatesh, Senior Consultant Urologist and former Director of NU Hospital, Bangalore. INU, okay, sorry, sir. We now move to risk-adapted strategies for advanced prostate cancer. To discuss this personalized approach in managing these advanced disease, we invite Dr. Sanjay Adla, Consultant Urologist, Apollo Hospital, Hyderabad.
Yeah. As we
Over to
get
you, sir.
there, the foundation to this session is important. We started with Huggins, and first thing, we are dealing only with metastatic prostate cancer, not the local disease. Second, it started with Huggins and hormones and androgens, and from there we moved on and on and on, went to estrogen somewhere, came back to androgens, and now we have a whole lot of things available to us. Can we use all of them interchangeably? In what sequence do we use them? And when to combine, when not to combine, is what Dr. Adla will tell us. He's an excellent teacher. I'm sure you'll enjoy this talk.
Now I have to live up to that, sir. Thank you very much. So we swapped it because he was covering a lot more of my topic and I was covering a lot of his topic. So Vivek is going to talk on my topic and I will talk on his topic. Both of them are risk-adapted one. So this anybody, if there are any younger people, a patient comes to you with metastatic prostate cancer, castrate-sensitive prostate cancer. These are the questions you have to ask. Is it synchronous or metachronous? Synchronous in that patient has presented to you with metastatic prostate cancer. So that would be called a synchronous or de novo metastatic prostate cancer, or metachronous prostate cancer, i.e. patient underwent radiotherapy or radical prostatectomy 10 years ago, now has presented with metastatic prostate cancer. The second one is whether the patient has got a low volume or high volume, low risk or high risk. It sounds almost all of them are same. Actually, they are not same. They are different. They are treated different. They behave different. So that's the reason the first stratification is he presenting to me, or he presented 10 years ago, now he has come back with metastatic, because the genetics are different. Why is it different? Is volume and risk the same? No. Volume is used with respect to the charted criteria. Risk is with respect to the latitude criteria. And again, when you look at them, it looks the same. But the biggest thing is the presence of Gleason score in the risk criteria, whereas that one is not there in this. And the second element is all this is based on standard imaging, i.e. CT or MRI scan along with a bone scan, not based on PSMA PET. But in India, everybody's birthright is a PSMA PET, so we extend it to PSMA PET as well. Nobody has done a comparison, but you would expect that common sense would say what a bone scan would pick up, a PSMA would pick up, and it would pick up a bit more. So why does it matter whether it's a synchronous or metachronous? Look at the numbers. Somebody comes to you with a synchronous, i.e. de novo low volume metastatic prostate cancer. Median OS is 52 months. I would probably think it's a bit more now. This was at the outset. Now probably it's around 100 months. Synchronous low volume metastatic prostate cancer. Metachronous low volume, we are looking at 92 months. So it helps us in telling the patients, counseling the patient. Same with respect to the synchronous high volume. Rarely, I haven't seen a metachronous high volume. Because if you think of it, if the patient's genetics was so bad, he would have come to you with de novo metastatic. So rarely do you find a metachronous high volume metastatic prostate cancer. So these are the two questions. Is it synchronous metachronous? Is it low volume or high volume? We do tend to use the low risk and high risk. Why is that important? If you see there, Arason's trial, you don't need to know what the trial is. It will come. I'll come to it. But if when you use the high volume and low volume, in the low volume there isn't any difference. In the high volume there is a difference. But when you use the risk stratification, there is a difference in both. So you can't just extrapolate saying that high volume and low volume or high risk and volume are the same. Every time you have to compare volume to volume and risk to risk. Same patients, same study. When you use the risk stratification, there is a difference between low and high volume, whereas none when you use the volume. And this is de novo and recurrent metastatic prostate cancer. Stampede trial, everybody has to know about it. Some baseline numbers. If anybody is going to any exam, anything in the metastatic, if they say what is the evidence, just say Stampede, more than 50% of the time you will be right, because they have done an amazing job with it. So in 2005, and again this one is a baseline, 2005, a patient who came to me with a metastatic prostate cancer. I was a urologist in 2005. I don't look that old, but I was a urologist in 2005. We used to give them ADT, and when they progressed, you would add bicalutamide. When they progressed, you would stop the bicalutamide, and then you would add stilbestrol. Then you would add CRPC, you would add zoledronic acid. Then you would give docetaxel, it would give you about 4 months survival benefit. Then ketoconazole, then low-dose steroid. All this gave us 36 months. So a patient who came to me with metastatic prostate cancer, at that time we did not have the concept of low or high risk or volume. We just said metastatic prostate. These were the numbers that we were giving. Stampede questioned that. It said, what if we do front loading, i.e. everything at the outset, not one after another. It was a game changer in that it asked more baseline questions that we were frightened of asking. Give docetaxel from day one. Nobody even thought of it, but they tried doing it. And they didn't ask one question. They asked 5 questions right from day one, saying that, what if I add this? What if I add this? What if I add this? And this is multi-arm, multi-stage, in that if they had to do all these trials, one after another, it would have been my lifetime and their lifetime. So what they did, they had one SOC arm, and then these are all the comparators. The SOC is a very, very new term, in that whenever you study any trial, you have to say what is the control arm. Generally, control arm is a placebo arm, but nowadays, like even the darolutamide study came to us, and the darolutamide study was comparing ADT plus darolutamide versus ADT. We are in 2023. You cannot give just ADT. That's inadequate treatment. So we just said, no, we can't. So SOC is whatever the standard of care on that day is. In this one, the standard of care was, it kept on changing. It started off with ADT. The day they had the evidence that docetaxel was better, ADT plus docetaxel became the standard of care. So whenever you see a trial, try to look at what is the control arm, because the control arm determines whether the efficacy is actually true or not. So these are the ones that placebo currently is not the standard of care. So this is what the full form of that is. Staggering numbers. If you see that these are all the numbers, started in 2005, initially started off as intercontinental trial. I was there for the initial discussion when they were happening in Christie Hospital, 2005, and then it became the Stampede trial. Overall, if you see 12,000 patients recruited between 2005 and 2023, not even a single metastatic patient in UK would go without being included in this Stampede. Every metastatic patient, that's why they could recruit that many number of patients over that much duration of time. Inclusion criteria, they had metastatic as well as locally advanced prostate cancer. There were 18% of them were locally advanced prostate cancer. Majority were metastatic, and almost majority of them were de novo metastatic. So these were the initial 5. All of them started from day one, and we have got new ones added in. But if you see there, the SOC kept on changing. SOC was ADT plus or minus RT. The moment, this was January 2016, the evidence came saying that docetaxel was giving survival benefit. They changed it. Docetaxel was added in. Then docetaxel or abiraterone was added in. So this is all what we know of. Very difficult to read because urologists are just simple brains. So if you say this, in a patient who presents with metastatic prostate cancer, if you give them docetaxel, you get 20% survival benefit, i.e. the hazard ratio is around 0.78 to 0.8. It will be around 0.7 if you give them ARPI. So that's the difference between giving at the outset. The other one, these are the current numbers, and this is what we got from the control arm of the different trials. So a patient who presents to me with de novo, low volume metastatic prostate cancer, what do I tell them now? ADT alone gives me 76 months. When I say ADT alone, it's not ADT alone, ADT followed by docetaxel, followed by abiraterone acetate, followed by something else. So it is not just ADT until they die. Compared to ADT plus docetaxel give me 93 months, ADT plus abiraterone gives me more than 100 months, ADT plus RT. So we are looking at de novo, low volume metastatic prostate cancer patient presenting in 2026 has got a lifespan of almost 10 years. That's what you can tell them, saying that if you follow whatever the medication and if we trust the evidence that is there, your median lifespan is going to be around 10 years. What is the numbers with respect to the high volume metastatic prostate cancer? ADT alone. And again, I'm emphasizing ADT alone is not ADT alone. ADT followed by the other drugs. 34 months. ADT plus docetaxel adds another 10 months. Abiraterone adds another 10 months. ADT plus abiraterone plus enza doesn't add anything more. ADT plus docetaxel plus abiraterone again adds around 8 to 9 months. Same with this one. So from 34 months, we have increased it to 64 months for a de novo high volume metastatic prostate cancer, and that is since 2015. Okay. Can we prevent the onset of CRPC? These are what we call as the ICECAP meta-analysis. ICECAP is intermediate clinical endpoints. Why am we using intermediate clinical endpoints? In a wrong way, prostate cancer patients don't die. So you can't wait until they die because the clinicians might die before the patients die. So you want intermediate clinical endpoints to indicate that what is the drug that is making the difference. So can we prevent castrate resistance, whether that adds to the overall survival? So this is the piece 1, which had 2 by 2 factorial, but in essence, this is what it was. Patients were allocated to docetaxel, but only 50%, ADT plus docetaxel, ADT plus docetaxel plus abiraterone, ADT plus docetaxel plus radiotherapy, and then ADT plus docetaxel and radiotherapy, if I'm right. Docetaxel wasn't given to only, was given as in they were recruited into that, but only 50% of the patients had it. This is just to indicate that they were actually not our typical patients. So if you look at the PSA, in this metastatic, it was 10, 9, 13, 12. This is not our type of patients. When you have a metastatic prostate cancer patient in India, he will come to you with 5,000. Nobody had 5,000 PSA. Highest PSA was 62 for them. So these are not as high volume as we tend to see, but those are the numbers. And what this is showing is castrate resistance-free survival. Each treatment tends to delay the castration. Yes? So whether you add docetaxel, it delays the castration. Abiraterone to docetaxel delays the castration. Abiraterone plus radiotherapy delays the castration further. However, does that change the overall survival? Currently, it doesn't seem to in high volume metastatic. It does tend to do in the low volume, but not in the high volume. So going back to the ICECAP meta-analysis, the castration, onset of castration is delayed if you give them local RT along with whatever systemic treatment, but it hasn't yet made an overall survival difference. So take home message is TURP and orchidectomy is obsolete, it is inadequate, it is dangerous, you shouldn't be doing. ADT plus is the standard, that's the minimum that you are going to do. ADT plus RT, probably if you want to delay the CRPC. Thank you.
Thank you very much, sir.
Where we have several options. What is left? We have excellent teacher to tell us. Yeah, we have an excellent teacher to tell us. We have all this. Now, how do we choose which? When? Where? When do we say enough is enough, or when do we say there's more coming? Dr. Vivek. We'll take questions after both of you have finished, if there are any.
Thank you very much, sir, for the kind introduction, and thank you to Srivatsa for this opportunity. And also thank you to Sanjay sir for setting up my stage so perfectly. So we will not be covering some of this, local therapies, different ADTs, and what sir has already covered. And as sir said, that metastatic hormone-sensitive disease is quite heterogeneous, and now it's proven beyond doubt that we need something along with ADT as the standard of care, because we need to hit hard earlier in the course of disease. But unfortunately, if you see, a recent study still showed that about half our patients are still just put on ADT alone. So what that optimal X requires a consideration of multiple disease as well as patient factors. Ultimately, we will move towards genetic testing and precision medicine, but as of now, it's still a minor in prostate cancer. So I joined urology in 2010. Before that, there were about 5 drugs. We had just one stick with which to, treat everything. Since then, we've had another 15 come up. So this rapid, change has left some unanswered questions, like sir said, that what to select, when to select, and how to follow it up. So this is a classic case, a pretty young, fit guy with a high PSA and multiple bone mets and lymph node mets on evaluation for prostate cancer. He had an orchidectomy done elsewhere. So what do we add next? So these are all the options the EAU guidelines give us. Docetaxel, strong, apalutamide, abiraterone, enzalutamide, all have a strong recommendation. Darolutamide is still a weak one, but it should change in a year or two. And the new one is triplet therapy, where you have ADT plus docetaxel plus abiraterone or darolutamide. I do send some fit patients to the medical oncologist for triplet, but they are not really that keen. It's still quite niche. They feel it's probably too toxic right now. Most of them refuse. They still keep it on, a doublet. So I think we'll kind of keep that away for the moment. So which agent do we start with? The decision making involves a number of factors. First is of the patient's clinical status, age, comorbid diseases, performance status, fitness for each of those particular medications need to be checked. So sugars and diabetes, people often think is a contraindication for abiraterone, but if it's well controlled, usually there's really not much problem. You just may need to monitor them more frequently. Tumor factors, I think sir has covered all these, the low volume, high volume. And what is important is, in low volume disease, we've seen that docetaxel probably doesn't work as well as the androgen blockers. Of course, we take into account patient preferences, and economics in India does, play an important role in what's happening. When you choose these treatments, do we have any data comparing both of them? No, we don't. We have data which is indirect. We'll go through that. And we have to take into account the toxicity of each treatment and the monitoring. Abiraterone does need a little more intensive monitoring, but enzalutamide is not as benign as a lot of people think. So in comparison, there is no head-to-head, so we have to take a long circuitous route to get to the answer. There are some issues with the trials of enzalutamide. They had used a lot of additional treatments in the enzalutamide arm which showed benefit, and there is less data on quality of life, and the initial endpoint of Arches trial was radiologic progression-free survival, so which is considered less oncologically good as compared to overall survival. So we compared indirectly. There were 2 trials, both in 2020 meta-analysis. A network analysis is one where if the control arm is the same, you can compare across different treatments. So they used more or less the same drugs, but they reached completely different results. The one in European Urology showed that the hazard ratio was best for enzalutamide. The one in Journal of Urology showed the hazard ratio was best for abiraterone. So still a bit of a head scratcher. So in terms of direct head-to-head comparisons, we have none. Indirectly, we have conflicting data, but probably we can say that both do really well. So then you choose based on other facts. Side effects, we do know there can be more with abiraterone. Monitoring may be more, intensive. But enzalutamide, often we do have to reduce the dose because of severe fatigue. Abiraterone is significantly cheaper, and you can use a low dose, though I don't have, personal experience with that. So one size clearly does not fit all. When you start, you have to choose, tailor it according to both patient, tumor, and toxicity of the treatment factors. Once the patient has progressed, then how do we sequence the next treatment? So what is important, these are some of the key concepts which we need to keep in mind. There is a lot of resistance among the androgen blockers. So the crossover or using one after the other is extremely limited. And there is, of course, little data to guide the sequence. And the most important factor would be what was the treatment received before. So if he's received docetaxel, you can use an ARI. If he's received an ARI, you can use a docetaxel. So there is a gap between another ARI. So we have good data for sequencing that ARIs work well after docetaxel. But what's important here is that there are multiple studies which show almost zero benefit of abiraterone after enzalutamide has already been used. So if you use enzalutamide up front, you're kind of killing using two arrows at one target. And this was an important paper, which was a phase 2 crossover study, which showed a 36% response of enza after abiraterone had been used, but only 3% vice versa. And the median overall survival was probably better if you gave abiraterone up front. So if possible, we would prefer to give abiraterone up front. It needs a little more monitoring. It's a little more intensive. Patient fitness you need to check. But if at all possible, probably that's the way to go. Now you've progressed to the third line. So where do we go from here? Next trial is CARD, which was for cabazitaxel, still not very commonly used. It did show actually a benefit if you compared it to the second androgen receptor as a third line therapy. So patient has received docetaxel, he's received one androgen receptor inhibitor, you don't know what to do next, then probably cabazitaxel is one option. Again, medical oncologists have to decide. Then we moved on to olaparib and rucaparib, again in the same setting, third line, which was also approved. And it is currently, especially they are useful in those who have genetic mutations. Now, newer studies, the last line, if you combine, it's getting very, very complicated even for me. If you combine the PARP inhibitors with abiraterone or enza, you can use it earlier. That's just after docetaxel. So it's too many combinations, too many, I just refer to medical oncologists. And finally, this is the next trial, which is the lutetium trial, but we have to be involved. Lutetium and actinium. So they were also used as third and fourth line. So we have so many lines now, and each line is moving slowly one step earlier in the treatment. So we have to keep a watch on that. But we have lines, so we don't have to give up very easily. There are a lot of things that can be tried, and these are generally not that toxic. So these are things which patients tolerate quite well. So to conclude, ADT plus X is needed. Many drugs, many options available. Both to start off with, Abi and Enza, both are extremely effective. Patient factors, toxicities play a role. But remember that abiraterone probably does not work if enzalutamide is already used. So you can think that this could be one potential sequence. And one size, again, does not fit all. So it depends on the prior therapy. Thank you.
Thank you. I think both the speakers might take few questions, if there are any.
though there is no head-to-head comparison, sir, recently there was a community study, Rome and Roma studies, where they compared apalutamide to abiraterone, apalutamide to docetaxel, apalutamide to darolutamide, and all of them. Yes. So enzalutamide, I find it very toxic. In that patient would not get out of bed. But it's surprising. It seems to be the case only in the South India. When I ask the same question in North India, for them the go-to ARPI is enzalutamide. They don't tend to have that much of a side effect. So I don't know why that is the case. So North India, the preferable ARPI is enzalutamide. Below the
same dosage.
Same dosage. Enzalutamide, there is no decrease, the normal dosage. The Peninsula India, it seems to be abiraterone acetate is our go-to drug. It's cheaper and it's not that big a concern whether it's diabetic or not. Yes. RGCI might be an exception.
No, I agree with you, sir.
Yeah.
Enza works for us.
Yes.
I always argue why it doesn't.
I
work
don't know
in
why patients don't get out of bed. When I give them and I see them at a month, patient will say, I will die, doctor, I won't have this.
Can you give us some... No, if you can...
Yes.
They need different gut systems.
No. I think we need to... I think we actually need to look at several other numbers like BMI, lean body mass, and perhaps also the genetic profile to see if there is any difference between these two groups. Maybe that will come up in the years and decades to follow. One question that I have is this. See, we know all these are toxic. We saw that with immunotherapy also. And data is coming out, particularly from India, of reducing the dose. Would it be possible to do that for carcinoma prostate?
Yes, in a sense is the answer. So we tend to reduce it more for financial reasons rather than toxicity. That's the first one. So the enzalutamide, because it's an androgen receptor blocker, at least there is no evidence to say that lowering the dosage does anything. Abiraterone acetate, it's an enzymatic process, so they have studied it at a quarter of the dosage. That is fine. The apalutamide, for me, it doesn't make sense as to say why it should be more efficacious, because the molecule is almost similar. It's like a twin of enzalutamide. And then the second element, so it seems to be a bit more efficacious. If you look at, they have compared quite a large cohort, 8,000 to 2,000 patients cohort. Then the second is apalutamide seems to have lesser toxicity compared to enzalutamide. And I don't have any financial interest in any of the companies, but it has got financial toxicity. It is 25,000 compared to around 6,000, and this is lifelong medication we are talking of. So each 1,000 adds a lot to the financial burden to the patient. So unless we have a bit more of financial assessment and say, okay, for every 20,000 extra they are spending, how much of a value are they getting out of it? We don't have that number. So for me, go-to drug is abiraterone acetate unless there is a reason. And my second go-to drug is apalutamide currently, just because toxicity is lesser and efficacy seems to be as good as the other medication. Where we can add what you are asking, whether toxicity is, we are blocking the androgen receptor completely. These are super androgen receptor blocker. So why am I castrating them? The reason is all the studies have castrated them. That's the reason you say, okay, I want to castrate as well. But there isn't any. The EMBARK study is the first one wherein they compared enzalutamide on its own, but that was in a BCR setting. That's the first study where they said, can I just use enzalutamide without LHRH agonist? And what they found is, at least in their parameters, they said LHRH agonist along with enzalutamide is better compared to either enzalutamide or LHRH agonist.
Now, can we go back then to the earlier paradigm where we said, we do orchiectomy,
yes,
and then we find that there is metastasis, and then we go for the adrenal, we go for aromatase, we go for the other things. Can we draw some parallel between that and this? Why we still do an orchiectomy?
Because that's what we know how to do. So all the studies have always gone with SOC plus. So SOC for us, since Huggins and Hodges 1941 was orchidectomy. So unless we keep on asking the same question, I'm anyway blocking the end receptor. Why am I doing an orchidectomy? And that will take out testosterone out of the system.
Yes, Dr. Venkatesh.
Yes.
Do an orchidectomy, sir, in routine practice. Which is the most ideal practice? You do it upfront, or would you wait for a while? Do it when patient moves into CRPC, or when?
Okay. So the way I tend to do it is I ask that question at 3 months. The reason why I don't ask it at the beginning is there is so much of emotional pressure you are putting on the patient, saying that you have got a cancer, it has already gone to the bone, you have got stage 4 cancer, and then you say, I'll take your testicle off. So rather than that, I say, okay, I'm going to suppress doing the testosterone. There are this option. If you do not want to decide how you want to do it, we can always interchange. Whether you go on injection or tablets or orchidectomy, if they say, sir, do an orchidectomy, I'm fine with it. But I don't put a gun to their head and say, decide which one you want. Easiest one is to delay that decision. So normally I ask that question. Once the PSA has gone down, they are castrated, I say, now tell me, do you want to continue on the injections or do you want to have an orchidectomy? That's how I tend to go a bit later.
Now we know that in the metastatic situation, theoretically,
Localized prostate cancer has been recognized.
Measure. So we in Rajiv Gandhi, what we are doing is we will give them for a year and then we will see what the PSA is doing, what the PET is showing and how much is the response. Sometimes you will be surprised, there will be just some minor specks of disease. Fry those areas with a saber and then stop. You can even make them completely hormone holiday free. So I have personal patients under follow-up who are completely ADT free and they are still going strong. It all depends on how they responded. So
Very quickly, but then with such low PSA levels, how accurate? So you're heavily relying only on PSA because the imaging is grossly inaccurate.
Correct. So very good question. So
I think
what
these
happens
ladies
is
are asking us to stop, I think.
Last response.
yeah, so this another very good question. So PSMA PET does not always show all the disease. If you really ask, a whole body MRI scan will still show you areas of metabolic activity where the PSMA PET is silent. So look at the whole patient and then compare before to after. to answer your question about when do you do orchidectomy, in HSPC, you really want to not do an orchidectomy because there is the proven advantage of doing intermittent hormone therapy and it delays CRPC. While if it has become CRPC, then you can go ahead do an orchidectomy because there you have to do indefinite ADT anyway. So,
shall I just with your permission one comment? Earlier, we used to give intermittent, of course, in here there is no level 1 data. The initial, whatever the trials were there, you give hormone therapy for 1 year, look for the PSA. Whatever the current data available, though data is very little, at 7 months, I don't know how they got 6 months versus 7 months. At 7 months, if the PSA is less than 0.2, that is the cutoff they have given. That is with only standard ADT, not with all these. By adding all these, probably we have seen PSA dropping even less than 0.1. In such cases, we are selecting cases. We have more than 20-30 cases. In fact, longest patient who survived was 13 years. Metastatic prostate cancer, 4+5, he will have some genetic favorable risk. He survived for 13 years. He developed a colon cancer and he died of that. So he was, he was on active surveillance. I mean, he was on intermittent therapy. He used to come once in 2 years, 3 years. Some PSA will go up, just give. I mean, this is an anecdotal case, but we have plenty of cases like that.
Break for the next session.
Sir, Dr. Rahul Pradhan from Bakchi Shankara Cancer Hospital. One scenario where we all of us are very constrained is cardiac patients.
We have a responsibility to stop this session.
Right, sir.
We can take it up later.
Right, sir. Thank you.
Sorry, Rahul. Thank you.
Thank you, sir. Now we request the chairperson to hand over the memento to Dr. Vivek. We request Dr. Ramesh to hand over the memento to our chairpersons. We now move on to an interactive panel discussion moderated by Dr. Saurabh Patil, Consultant Uro-Oncologist, Fortis Hospital, Mumbai. Joining the discussion will be the panelist, Dr. Raghunath SK, Senior Consultant Urologist, HCG Hospital, Dr. Giri GV, HOD Radiation Oncologist, Sri Shankara Cancer Hospital, Dr. Manohar T, Consultant Urologist, Apollo Hospital, Bangalore, and Dr. Sanjay Adla of Apollo Hospital, Hyderabad. Panel discussions are always exciting because this is where evidence meets experience and occasionally a friendly disagreement. Over to you, sirs.
Thank you so much. And thank you, Srivatsa sir, for giving us this opportunity. Yeah, good afternoon, everyone. So thank you, Dr. Srivatsa, for giving me this opportunity. We will be discussing on few scenarios in prostate cancer. I have been asked to limit this in 3 particular scenarios. And since everybody is having now the waiting for lunch break, I should be moving forward. So first case is a routine case that we see in day-to-day practice. 60-year-old male, asymptomatic, incidentally detected, high PSA. Obviously no comorbidities, no nothing. And then DRE is normal, benign, no significant family history. So Manohar sir, how should we proceed in these cases?
Yeah, he is asymptomatic, no LUTs, and there's a non-tender prostate. I would like to go for an MRI.
Okay.
MPMRI.
So good enough, but we wanted to repeat the PSA from another lab. We repeated the PSA.
There's no pus cells, there's no tenderness.
No, nothing, everything been ruled out. Yes, yeah. You are absolutely right, but we repeated the PSA from another lab. We did free by total as well. Again, it is in the kind of, yes.
Yeah, I mean, in our scenario, actually, PSA, we are more bothered about, not like West. Here, we have a lot of fluctuating PSA. Because once, 5, another day it is 12.
Correct. Maybe because of chronic prostatitis.
We're having this problem, actually. So I don't believe on this PSA kinetics as far as in Indian patients.
Okay.
But, I don't having repeated this, probably we'll wait for about few days to give an antibiotic for about 2 to 4 weeks, and then
even if patient does not have any symptoms.
Yeah, that's what I mean. even now I would like to go for MPMRI.
Yeah, correct. So we listened to you, we did MPMRI, and then there were 2 pyrites, 3 lesion, one right peripheral zone, 14/9/8, and another in anterior fibromuscular stroma.
Can I just make a comment? We have to give value to every clinical contact in India. What I mean by that is it does take a patient quite a bit of time for them to come up to you. You have to make maximum out of it. If you say that, okay, the PSA looks okay, come back in 6 weeks' time, we don't audit our numbers. There will be some patients who will never come, they will come with metastatic at 10 years. So I know the PSA fluctuate, but the repeat PSA thankfully came 6.9. Immediately you hold a clinical contact in India is very difficult, just because there is no organized health system.
At the same time, I would say again, MRI,
I understand that's not a reason to overtreat, but you just have to judge, is this patient going to come?
So again,
if
we
there is any
counsel-
doubt,
yeah, correct.
hold on to
Absolutely.
it.
Agreed. Yeah, agreed. So next time I will not repeat the PSA, straight away MRI. And so 2 pyrites, 3 lesions, and localized, well-localized lesions again. So to add up to this confusion, so Dr. Sanjay, what should we do?
The elevated PSA is there.
DRE
Patient
normal.
is in the right age group. There is some abnormality there. So any of them, either elevated PSA or any pyrite 3 on the MRI individually are an indication for me to do a biopsy. I've got 2, more than enough for me to consider doing. Currently, I do a transperineal real-time fusion under local anesthesia. That would be my standard of care.
Okay, so to again add up to the confusion, we did review from our own MRI specialist. He said it could be 3 or maybe 4, again, no information. Again, we are on the same path. We did biopsy, 12-core systematic. It was benign, no malignant tissue. So whom to blame now?
Actually, by definition of the anterior zone, if it is more than 1.4, it classifies into pyrites 4 actually. But I don't know where it was missed. Maybe there is a...
So the take-home message from that one is almost every meeting of us should have how to read an MRI scan. The earlier we become independent of the radiologist in reading the MRI scan, the better it is. If I have to blame, I would rather blame myself rather than say I am inadequate at reading the MRI scan.
Absolutely.
So I train up myself. Now I read every MRI scan myself. I never go to a radiologist.
It also depends on who has done the biopsy, whether it's truss-guided, transperineal, transrectal, or finger-guided. No, standard 12, even now, people are taking standard
So
12 by...
agreed, yes.
If you go back, I mean, the lesion is actually in the anterior.
It was anterior, correct. So it is definitely, high chances to miss it. Yes,
Yeah.
absolutely right. So theoretically, what are the causes? Falsely high PSA because of prostatitis, falsely positive MRIs because of inflammation, nodular precursors, inexperience of radiologists, over-interpretation, poor protocols, and this should be falsely negative biopsy, False negative biopsies, again targeting error, we are missing the small tumors. Then operator inexperience, urologist inexperience in doing the biopsies, and inadequate sampling. And lastly, obviously, pathologist. So MRI, we know that it has a good sensitivity and negative predictive value, but has a slightly lower positive predictive value, and this is the trial that gave us a good idea about the predictive values. And if we see here, so the false positive rates or the positive predictive value with MRI is, even with the clinical significant cancer, is still 50%. In this, the clinical significance definition was 4+3. When it reduced to 3+4, then also it increases to 65%, but not more than 80% or 90%. That means when we are seeing a positive lesion on MRI, there is almost 65% chance that it may be malignant, but still we are not very sure. So again, we have this picture, we have the MRI. Now back to our question, what should we do next, Sanjay sir?
So since 2023, I think, they have started including the PSA density as a part of the...
Very good.
So PSA, pyrite 3 with a PSA density of more than 0.15, that's a definitive indication for you to do a biopsy. Again, the same thing here, in that you have already done a free to total PSA and it's less than 25%. And there is a pyrite 3/4 lesion. And I know it is benign, but it's always dependent on what kind of a biopsy has been done.
Correct.
If you're not sure of it, then I would rather repeat a biopsy. going by the other one, this is not going to kill him. There was a good Bob Javan paper saying that each number of biopsies that it takes for you to diagnose a cancer, the significant cancer volume keeps on decreasing. Did I make my point? On the first set of biopsies, second set, third set, fourth set, if you pick up a cancer on the fourth set, the probability of picking up a significant cancer is much lower compared to the first time.
Right. Good answer. So again, in this paper, what they followed up this particular 88 men
3 months.
after.
So when would I do it? 3 months.
Okay. Directly biopsy or imaging?
No, he has got an MRI scan. I won't repeat it.
Okay.
It would just confuse you more because you have already done a biopsy and you're doing an MRI scan within 3 months. It will confuse you more.
Okay, but this particular paper said that if we repeat this MRI after around at least 6 to 12 months, then almost 35% had a good resolution from Pirates 4 to Pirates 1. And another 38 had Pirates 4 to Pirates 2. Ultimately, only 15% had positive cancer. So if the takeaway here is, if we find a lesion of Pirates 4 or 5 on repeat MRI around 12 months after, then the chances of picking up positive cancer is high. So we should at least wait for 6 months, around 6 months in this particular scenario to get a good idea. And if the Pirates is lower, then probably we should avoid taking biopsy. Am I correct? Or
it's not going to kill him. Even if he has a cancer, it's not going to kill him. And if you go back immediately, you are going to increase the complication rate. So if you have to wait and you know patient is going to come, 6 months is fine enough.
right. So Raghunath sir, like Sanjay sir said, it's a birthright to do PSMA PET scan in India. Should we be doing PSMA PET scan in this scenario or in a biomarker?
It's not required in this case. There is no evidence for that. Of course, new biomarkers are coming. It's still experimental. It is not standard.
So in practice, we don't use. Correct. So to summarize,
can I do the other way? There is the primary score that is coming for PSMA PET for diagnosis of prostate cancer, and when they have done the comparison of multiparametric MRI scan to the primary score is better. Yes, primary score is better. So I think in the near future, a PSMA PET will be the all coming. Elevated PSA, you do a PSMA PET and then do a targeted one. PGI are already doing a PSMA targeted prostate biopsies. And then you would just see where the lesion is and then do the biopsy. So primary score currently outscores PIRAD.
Okay, good. So again, to summarize, we should reassess PSA, review biopsy, MRI, all these things. Monitor PSA. Don't be in a rush to repeat the biopsy. At least wait for 6 to 12 months. Repeat the MRI. If MRI shows Pirates 4 or 5, then the biopsy. Again, this biopsy should be, if possible, fusion biopsy, like Dr. Shivas had discussed. And especially for small anterior lesions, and take at least 3 or ideal 4 cores from the targets. We are not very sure about the PET scan and biomarkers as of now.
Just repeating what Srivatsa said, please, the last thing you want to do is repeat a 12-core biopsy. Don't do that. As I said before, if you just do another 12-core, you'll get the same answer. Do something different. Do a 12-core and then do a cognitive fusion or something else.
Targeted.
If you have done a finger-guided, do a truss-guided. If you have done a truss-guided, do a cognitive. If you have done a cognitive, do a transperineal. If you have done a transperineal, do a real-time fusion. Something better than what you have done before.
Good. So moving on to second case, this is a 66 years old male, RARP done in 2021, grade group 4, must be in Bengaluru because there were no margins positive, everything looks clear, and also PSA was well controlled. Again, he was so happy that he lost to follow-up after around 2 years and then came with a rising PSA 3.8. PSMA PET was done, which showed pelvic lymph node with a common iliac lymph node and 2 vertebral lesions in 2 lesions in vertebra. So to summarize, this is kind of a oligometastatic recurrence or metachronous oligo recurrence. So Sanjay sir, how should we define this oligo recurrence or oligo thing?
Don't define it.
We don't have any concrete number.
That's why I don't use, there are 8 definitions for this one. So I would rather say go back to the same volume-based one, which is a better evidence-based rather than an oligo. Okay. Or if you wanted to use it, less than 5.
Okay, good, correct. So in few of these studies, it has been 3 or few, it is 5, but it should not be definitely more than 5. So restrict to 5. So Giri sir, now to you, what should be the ideal treatment in this patient?
So I guess it would probably be the standard of care will probably be ADT with APRI.
Correct.
And then wait and watch, and then of course consolidate with radiation per se. But I think there is, yeah, it's probably now I think people are looking more for metastatic directed radiotherapy, that is without ADT, to prevent, you know,
To delay
to
the
delay
yes,
the
correct. Toxicity
probably,
of
yes.
ADT.
And there is enough and more evidence, I think, that's right now cropping up. Starting with the Sabre comet itself, which started off, though the volumes were small, the number were small, but by and large, I'm sorry, but by and large, I think probably the standard of care would be, of course, as I said, ATT with the APPI and consolidation of radiation. But nowadays, I think it would be probably people would be more comfortable with just doing radiation and then delaying the ADT. Would that be the?
So in practice, how would you do it? I mean, the dose and how would you plan it?
Okay.
Initially ADT followed by SABR or straight away?
I would probably look at SABR itself to start with, and then probably delay the ADT.
So no ADT, directly SABR, and then wait and watch.
The volumes, of course, would be small. As I said, I mean, the oligo, keeping the definition of oligo, probably in this particular case, the vertebral mets would be taken care of with about 24 gray and 3 fractions itself at 8 gray per fraction. And probably for the lymph nodes as well, we probably want to fraction it a little more, but then we can probably go ahead and wait and watch after just giving radiation.
Good. So we are getting the confidence because of this particular trial, which is published in February 2026, Wolverine trial, which is a systematic review and individual patient data meta-analysis, which is considered to be superior than aggregate data in terms of subgroup analysis. And then it is a pooled meta-analysis of 6 trials, prospective trials on MDT. So which gave us the strongest evidence on MDT so far and the clear benefits as far as these survival outcomes are concerned. So if we see here, across all the parameters, all the trials, we get a good hazard ratio, whether it is progression-free survival, radiographic progression-free survival, or even a castration-resistant free survival. So we can delay all these castration-resistant progression with a good hazard ratio. But when it comes to overall survival, it's a near miss. The hazard ratio is still good and on the left side, but the p-value has not met. So maybe there is no 100% confidence in offering in the in our clinical practice. In all, again, all the subgroups, whether it is castration sensitive, it is resistant, the number of lymph nodes, the sites of lymph nodes, everywhere there has been a highly consistent benefit across all these subgroups. So again, Girish sir, back to you. How do you select these patients? Like you said it, but
obviously it would not
only
be
for metachronous or
only for metachronous. It would probably not be for synchronous.
Again, metachronous, low volume.
Low volume, not high volume.
Correct. Very nice. So
would there be any role for giving local pelvic RT to them? Because all the evidence.
So these are oligo. I will come to it. These are oligo recurrences. You are talking about oligo metastatic. I will come to it in my.
No, the same patient. You said there were bony lesions, there are lymph nodal lesions.
Correct.
And then when he started off, he said that he would give ADT plus ARPI and then consolidation radiotherapy.
With ACBR.
Why? Because we can?
No, I don't understand.
The patient is already metastatic.
My oligometastatic, yes.
Yeah, metastatic.
Correct.
You have already given done radical prostatectomy as a local treatment.
Correct.
What are we achieving by giving RT there?
So RT2 metastatic sites which are known to cause metastasis further.
So there is also evidence to say that you could also give local radiation to the primary as well.
Prostate. Whenever prostate, even if prostate is out.
Yeah, that's what I'm saying. There is nothing there.
To the tumor bed per se.
No, we tend to give RT just because that's what the evidence suggests, but the evidence is all predating ARPI. Yes, and we tend to give it saying that okay, it won't do any harm, but you will have a patient who was continent who will become incontinent, who has got much more irritative symptoms, and you will always have more local symptoms. And we are giving local pelvic. This patient is metastatic, and you know that recurrent low volume, they are going to have a long lifespan.
Correct.
So you don't want to impair their quality of life without evidence. I don't think there is any evidence for local pelvic radiotherapy in that sort of a setting.
Absolutely. So we are just giving radiation to metastasis and ADT. No local RT.
I would like to ask you a question. Since
The things is, you know that there is biochemical recurrence. How do you know there is no recurrence at the prostate site? There is no evidence. The PSMA PET may not pick it up, but you could still have microscopic disease left behind. That is why the concept of treating the pelvis came up. And definitely radiation is not going to worsen the incontinence when you give to a post-op setting. You can have some cystitis and proctitis, but not incontinence. And the dose we give is lesser in a post-operative setting as compared to an intact prostate. So that is the reason why I still think prostate bed should be irradiated and not just the metastatic sites.
Okay, thank you. I'll answer those 3 questions. So the first one, if the PSMA had shown or there was no metastatic, yes, then you can make a case for giving radiotherapy to the prostate bed area, just because that is the only focus of disease. In this one, the focus has already gone to the bone and to the lymph
So
nodes.
how do you know there is no disease in the bed, sir?
I'm not saying there is no disease. There might be disease.
It can have a local recurrence at the bed.
No, I'm not saying there is no disease locally. What I'm saying is there is disease elsewhere that I can see. I'm not saying there is no local disease. Yes, that's the reason I'm treating anyway with ADT plus ARPI. That's one. Second, to say that these patients will not have urinary incontinence, not in your clinic, in our clinic we see them. Second one. Then the third one, giving local pelvis radiotherapy to say that they will have cystitis. No, they won't. All the patients who will be, I'm not saying if they leak a bit, they will leak a lot following radiotherapy, whatever time period.
Sir, that is not what commonly is seen. There is those who already have incontinence post-op can remain or worsen, but those who don't have incontinence are not likely to develop incontinence after that. They might have cystitis. Yeah.
No, we have seen they are continent. They are continent post-radical prostatectomy. If you give radiation, they can become incontinent. We have seen many of cases.
That's not a rule, sir. That's what I'm trying to say. It is not a routine rule that everybody will become incontinent if you give radiation. That is the point I'm trying to tell.
Okay, let me add some numbers to this. Are you radiation oncologist?
Yes, sir.
Sorry. Okay. Okay, fine. No, I'm with him. So yes, 6% de novo incontinence is audit proven. So I will not argue about it, right? 6% bowel related side effects is audit proven. Yes. Third party audit. Okay. So next thing, the dose of radiation is not lower. It is lower if it was 74 to 76 for the index case. If you were giving 60 grade 20 fractions, you still will give 60 grade 20 fractions?
No, not for a post-operative no prostate, sir.
How much will you give?
We are not routinely hypofractionating in that situation.
So my radiation therapist does.
Yeah, that is still not.
I think this will go on and on. So we will discuss this in lunch because we have only 10 minutes as per Dr. Srivastava. So Raghunath sir, so without ADT, are we confident this is a metastatic disease?
I would like to give at least short-term ADT with.
In STORM trial, the intention was to delay the ADT. Okay, obviously volume, the number of patients are very low. But in practice, yes, you are right. I think we are not confident in delay. I mean,
may
stopping.
not give 2 years or 3 years. At least I will give for 1 year.
Correct. So this was for metachronous or recurrence. For synchronous, obviously no option. We have to intensify the treatment for as per the triplet treatment. Guidelines, NCCN, yes, they support this kind of MDT. But again, if we see EAU, maybe this is last year's EAU, so they don't have any confidence outside trials. So MDT, as far as MDT is concerned, NCCN supports this, EAU not yet. So to summarize this case, oligo recurrence, we have operated, then recurrence in few places, less than 3 places. MDT, with or without ADT, we don't know, maybe without ADT in future. Synchronous, de novo, but oligomets. Then obviously doublet, and in that doublet, it should not be ADT plus docetaxel. The doublet should be ADT plus ARPI plus local RT. Oligo progression, the patient was having ADT, ARPI, and then progressed to the more lesions, but less than 3 or less than 5. Then maybe MDT and continuing the ADT. And in synchronous high volume, which is very clear, de novo high volume disease, we have to intensify with the triplet. Moving on to case 3, young male presented with retention, no comorbidities, PSA is 28, DRE hard prostate. MRI show locally advanced disease, seminal vesicle positive, few sub-centimeter lymph node in left pelvis. Biopsy was done, grade group 4, PNI, perineal invasion was positive, PET showing Again, locally advanced disease, seminal vesicle positive with suspicious iliac lymph nodes. And then again to summarize, this is a young, locally advanced, high-risk prostate cancer with suspicious but clinically lymph node positive. So, Giri sir, I know obviously you will not do radical prostatectomy. So why not radical prostatectomy in such patients?
This is a high volume disease and this is high risk. So the question of what are you going to gain by doing a radical prostatectomy in this? I would probably want to treat this as a more conservative line of treatment with using radiation and probably ADT.
This patient came with retention. Even if it is not retention, with bothersome LUTS, then again the decision will be the same?
I would still think so. I'd probably not want to go ahead and try to do a radical prostatectomy for this.
Okay.
Complications with RT?
No,
Yeah, correct. That is the next question. Sanjay sir, you can take this question. So this particular patient, what complication would you expect after RT?
Worsening of lower inner tract symptoms.
Correct.
And
Requiring
hematuria.
multiple interventions, maybe
Hematuria.
retention, requiring TUR, hematuria, clot retention, requiring cystoscopy, hydronephrosis, hydroureter, requiring multiple DGS stenting, apart from gross cystitis and GI toxicity. So,
Can I go the other way around as well? In that a patient who has got retention of urine, when you give them ADT, almost
We can give them
70%
trial.
of them will have a successful trial without catheter.
but again,
So
when we give radiation to that, then
radiation
volume
should
will
almost
come down.
make it even more smaller with respect
It will
to the
become smaller, and therefore
smaller.
the
So
volumes will
I'm
become lesser for us to treat.
so I would not use just that as a reason for
Not doing RT.
No, not always. But in this one, do I expect it? Whatever you throw at him, he's going to progress.
multimodality treatment is
That's
required.
what I'm
Correct.
saying.
Correct.
So more importantly than the local treatment, he will need to be on ADT plus ARPI. It has shown that ARPI in locally advanced non-metastatic prostate cancer does make a
Work,
difference.
correct. So again, we obviously don't have any level 1 evidence to support RP, but again, we don't have any level 1 evidence for RT either. The whatever comparison has been done, it is RT plus ADT versus ADT. There are no head-to-head comparisons, and the literature, for example, this comparison, though retrospective, done in 2018 by American Cancer Society, it shows that across all these cases, locally advanced, T3, T4, Gleason's, high risk, the mortality is much lower in RP compared to RT. So they concluded that the patients who received RP are less likely to die because of the disease rather than the RT arm. And regardless of the stage and Gleason's, the overall survival, cancer-specific survival, favored RT. Obviously, this is an retrospective study. We can not take it as a norm. Raghunath sir, considering you are, so before that, on this, what is your take, Raghunath sir?
This is a systematic review and meta-analysis. Cox regression analysis was done. Almost 15 to 17%, 10 years cancer-specific survival and 10 years overall survival is better in favor of radical prostatectomy as a part of multimodality therapy. In that, I think around 30 to 40% required radiation. Here, the lymph node is plus or minus. We really don't know. We really don't know.
Correct.
Okay. So I would probably go for, there is no data for that neoadjuvant, but neoadjuvant is evolving. In clinical practice, what I do is I start him with neoadjuvant hormone therapy. Then I will discuss with him 3 months, 6 months down the line. If he is a candidate for radical prostatectomy, he has obstructive symptoms. I would go for radical prostatectomy. I will also tell him that you may require radiotherapy in maybe 30 to 40%.
Okay, so
despite of this may progress, but chance of survival is better according to this trial.
So no upfront radical prostatectomy, you will give this one. So considering your good quality experience in neoadjuvant ADT, so again to you, role of, you already answered this question.
We have that is, you have put up that. We presented that in before last year AUA.
I know.
131 patients. Now we have data of more than 200 patients of neoadjuvant. Our margin positivity rate is 13% in locally advanced prostate cancers, which is very less. And continence, there is no difference in continence when you operate on a locally advanced prostate cancer or localized prostate cancer, provided you have given ADT, neoadjuvant, intense neoadjuvant ADT.
Sanjay sir, any comments on how would you practice neoadjuvant in such scenarios?
Okay. I generally don't practice, is my answer, neoadjuvant as a day-to-day practice, but this will in the near future, because almost there is neoadjuvant data from 1992 neoadjuvant data, but we were only using LHRH agonists. They took a long time to work. So that has been supplanted now with the LHRH antagonist. That's one. And then those ARPIs have made a dramatic difference. So it would be interesting to note there are very large randomized controlled trials that are running. So we should have some answer in this front saying that we have always done surgery versus ADT plus ARPI plus radiotherapy.
Three arms
Of
versus
course,
one.
surgery will be inferior in
Inferior,
that.
correct.
Yes. So that's the reason this has to give us an answer. Then the second one is, once you have done a radical prostatectomy, one thing for sure, once they have recovered, they would not have local symptoms, i.e. they would not have any more obstruction of the urinary tract, no more of those lower unit. Whereas once you have given RT, at any time point, they will keep on having more and more of the lower unit tract symptoms.
I would like to quote one Brazilian journal. They have published this. Locally advanced prostate cancers, after giving hormone therapy, radiotherapy, around 28 to 30% of them progress to metastatic disease. Out of 28 to 30%, 56% of them develop local symptoms in terms of hematuria requiring clot evacuations, obstruction requiring TORPs, local pelvic pain, and ureteric strictures requiring degescending. This published data is there. So probably by doing radical prostatectomy, it is not just a cure. You can take care of the local disease in the best possible way.
But if I can also add, just as much as the surgery has evolved, so has radiation. Nowadays,
No,
that you
they
can
have compared. They have compared no local treatment versus radiation versus surgery. Surgery gives the best results compared to even radiation, and worst is no local therapy.
Okay, so
I'm just saying that nowadays, I mean, the complication rates that has been just now has been alluded to, we don't get to see those many complication rates nowadays, especially with the kind of radiation that we are giving. We are escalating doses, no doubt, but our targeting is very much better right now as what was compared to earlier. So it's very unlikely that we are going to get that kind of a...
I think sir is right. In Atlanta trial, in oligometastatic and metastatic cancers, local therapy were compared. Focal therapy, radical prostatectomy, local radiotherapy, and no treatment. So no local treatment did worst. With radiotherapy did better than no local treatment. Actually, focal therapy did best. I don't know if we will agree to that. But this is now getting shown in EAU and AU. You will hear it if you go to those conferences.
Okay, so the bottom line is multimodality treatment. Whatever we choose surgery or radiation, it has to be multimodality. With surgery, I think in younger patients, we are giving him less of morbidity in future. But again, we have to wait for this SPCG 15 trial results. Till then, obviously, we will be continuing debating. Thank you so much. Any questions from the audience?
That was quite the interactive discussion. Thank you very much to everyone. Request Dr. Giri sir to kindly hand over token of appreciation to our moderator, Dr. Saurabh Patil, and our panelists, Dr. Raghunath sir and Manohar sir. After a stimulating morning session of academic discussions, we now move into what may be considered the most important session, which is the lunch break. And since many doctors are traveling back, we request you all to reassemble here within 2:15. Thank you.